it. I am able to listen to you, but I have simultaneously opened my laptop. So should I log in with?
Yeah, yeah. Now I should get. Now I should get. Yes, yes. Thanks.
Sir, close the other device. You have to open
Yeah.
only one.
Yeah. So is it okay?
Good evening.
Yeah.
Good evening, Bhavan sir.
Sir, close
Good
the
evening.
other
Good
device.
evening.
Good evening.
Hello?
Yeah, sure.
Yeah. So we are online now, and let me take you through the initial disclaimers. Welcome all. Good evening to everybody. And this is a MOA Day event with MOA President with us, and Ramesh sir is awaited. Let's get through the disclaimer part. We thank all our faculty for sharing their knowledge in such challenging times, and we wish our audience a healthy and safe day ahead. These webinars are also dependent on internet speed, so they might be unstable at times. Bear with us with any issues. We'll reconnect shortly after any problems. And use the information shared in the webinar carefully. I'll show you next how to ask questions for this webinar. So questions can be asked online on the website, and let me take you to the website of where you can ask the questions. So this is the web page where shortly the video will appear, and just below our title you can see the question answer page. You can ask your questions here and we'll relay it to the moderators. So that's all from my side. Over to Dr. Shinde to initiate the, over to Dr. Shailesh to initiate, and then Dr. Shinde will speak. Shailesh sir, go ahead.
Yeah, good evening, everyone. Respected seniors, colleagues, and friends. Today we have the MOA Spine webinar. This is the second webinar of the 4 webinars this month we have. And this is the activity of Maharashtra Orthopedic Association, which is started by Dr. Shinde sir from Sangli. And this is the subject of his interest also. Today we have a very interesting and lot of stalwarts in spine surgery. We have 3 Arvinds, and we have called this as A to Z in osteoporosis. So we wanted to start from A, like Arvind Goregaonkar sir, Arvind Kulkarni, Dr. Arvind Bhave, and it ends till Dr. Zaveri. These are the stalwarts. We all know Dr. Arvind Kulkarni is eminent spine surgeon in Bombay Hospital, and he's got extensive work, published a wide literature. We have Dr. Arvind Goregaonkar sir, who is one of the most prominent head of the departments and orthopedic and spine surgeon from Mumbai. We have Dr. Arvind Bhave sir, who is one of the most prominent osteoporosis man in Pune city, and we all know him by his techniques in osteoporosis. We have Dr. Bhandari, who is one of the very senior orthopedic surgeon who practices in Solapur, and he has got extensive experience of practicing orthopedic and spine surgery. And we have the rising star from Aurangabad, Dr. Vivek Deshmukh, who is working in Prima Hospital in Aurangabad and who is doing excellent work there. We have Dr. Priyesh Doke, who is working in Nagpur. He is also an eminent spine surgeon from Vidarbha region, and he's doing a great work. We have eminent and prominent spine surgeon from Pune, our Ajay Kothari, who is doing great work. And we have my colleague, Dr. Rajesh Parasnis, who we all know as one of the most prominent figures in orthopedic spine surgery. And we welcome you all for this interesting interactive spine webinar, starting from the A to Z, as I mentioned just now. And we would like Dr. Shinde, this is possible because Dr. Shinde's perseverance that he wanted to make these spine webinars useful for the practicing orthopedic surgeons all over the places, and not only in the metro, but in the towns and city places. Everywhere he wanted to have simplistic topics which are useful. I would like to invite Professor Shinde sir to enlighten us and say a few words. Shinde sir.
Thank you, Shailesh, for nice words. Good evening, dear colleagues. I am Dr. Ajit Shinde, President of Maharashtra Orthopedic Association and Chairman of IOCON 2020 Organizing Committee. Friends, as you all know, MOA was founded in 1983 on 1st May by our eminent and visionary mentors. Since the inception, MOA has always been actively involved in academics and improvement of orthopedic fraternity and the society. Since last 2 years, we are celebrating this day and perhaps the week. This year MOA Day theme is Together We Can Defeat Corona. And we had conducted a great full day program with various virtues on 1st May. I hope everybody has attended it. If not, the program is still available on Artho TV. The first MOA Day celebration began in 2018 by MOA past President Dr. Parag Sanchetti, and theme was osteoporosis and awareness among the public and all of us is necessary as to know of cases are necessary quite exponentially. So in our second spine webinar of MOA weekly activity and in continuation with MOA Day celebration, the topic for today's is osteoporosis spine A to Z about treatment protocols. We know osteoporosis is known as a silent disease, particularly seen in postmenopausal females above 50 and elderly males above 60. Commonly, it can lead to fractures of spine, hip, and distal radius. As per the study of International Osteoporotic Foundation, its incidence is same as any other chronic diseases which catch public attention, and even the consequences of certain osteoporotic fractures can lead to death too. The lifetime risk of having these fractures is around 40%, which is close to cardiovascular diseases. Most of the general orthopedic surgeons, not only in our state but all over the country, face this common yet underreported issue in their day-to-day practice. I will assure you that today's faculties who are specialized in osteoporosis management will guide you regarding definite treatment protocol, both medical as well as surgical. At the end, I wish you all and your loved ones safe life in this crisis. Now I request Dr. Shailesh Hatgaonkar and Dr. Rajesh Palashnis to continue further proceedings. Thank you all.
Thank you, sir, for your nice words and kind words and encouraging words for all of us. I welcome Dr. Arvind Goregaonkar, who has joined us. And hello, sir. We just gave your brief about to everyone, and we will be having the cases, only case-based discussions. We don't want to talk about lectures or anything. Mainly cases and everyone's experience, and then followed by rapid fire, only cases by ourselves. And I would like to invite Ajay Kotari to start with his first case. Ajay.
Dr. Shailesh, thank you for the opportunity. Let's start with the cases directly. Now, this is an 80-year-old gentleman. He has comorbidities in the form of diabetes, hypertension, and CVA. This gentleman is asthmatic and is on steroid inhalers for last many years. He had a fall 3 months ago, following which he had moderate pain. He continued doing his basic activities of daily living, but he had a refall a month later. And this time the one was 9/10. He took conservative treatment from a local doctor in the form of analgesics and some painkiller injection. But pain didn't subside, and this is the time he came to us. So on examination, his pain is in the dorsolumbar and lumbar region. His neurology is normal. So this is the X-ray that we did for him. So Dr. Arvind Kulkarni.
Yeah, so he has no neurology, right? As you said.
It is normal.
Yeah. And what I would like to understand from his history is the pain initially and pain now. Are there two different places or it is the same?
Same place, same place. And the pain has worsened after the second fall.
Okay. So what you can see, appreciate here is 5, 4, 3, 2, 1. So there is a L1 compression fracture. And so it's about 2 months. So, and the pain is not continues to stay. Probably it's getting worse.
Yes.
So, and this is without any management or with some.
He took just analgesics from a local doctor, but no, like he was
He's not been investigated for osteoporosis, treated in terms of osteoporosis, etc.
Not at all, not at all.
So at this point, I'll get a MRI done to see two things. One is if there is only one fracture, if there are two fractures, because he's had 2 injuries.
Okay.
So one is that. So this is after all the examination, etc., etc.
Okay.
At the same time, since the elderly gentleman, I would also get his electrophoresis, electrophoresis to rule out myeloma.
So the next question is in sequence, like now we got his blood workup done. So elderly gentleman comes to the OPD with fall, with pain. So blood work. So my question is, do we start with a basic blood workup? Do we do an advanced blood workup? Do we do an MRI scan straight away? Dr. Gautam Zaveri, your comments on this? Hello?
If a patient comes with a clear history of a domestic fall within the last few days, which is causing the back.
Hello?
Hello, can you hear me?
Yeah, yes.
So if a patient comes with a fresh history of fall within the last few days and is complaining of a fresh back pain, I generally do not go for investigations in terms of an MRI or anything at that stage. A basic X-ray is important to see whether there is an evidence of a fracture or not.
Okay.
As far as blood work is concerned, my biggest thing is this is an 80-year-old patient with multiple comorbidities. This patient is going to require anti-osteoporotic medication.
Correct.
So if I'm going to put the patient on calcium, vitamin D3, or anti-osteoporotic medication in form of denosumab or teriparatide or something, I need blood investigations. I do not start teriparatide when the vitamin D is low or calcium is abnormal. I do not start teriparatide in a patient with a high PTH.
Correct.
And if a patient has protein electrophoresis, which is positive, I do not want to start the patient on teriparatide. And therefore, basic blood tests are more important from the point of starting your anti-osteoporotic medication than for diagnosing whether this is a primary fracture or a secondary fracture at this stage.
Okay. So in view of a patient having taken a lot of analgesics for 3 to 4 weeks and not getting better, so we got his MRI done. So this is what the MRI shows. So the MRI shows
which is pretty much what Arvind was saying, that there have been 2 injuries, you must look for 2 fractures possibly.
Yes.
So what it is showing is there is a compression fracture at L1 and there is a compression fracture at L3.
Yes.
But if you see, both the fractures are showing evidence of edema or hyperintensity signal, and therefore pain could be originating from either of them, though L1 is more hyperintense.
Correct. So this
the
is
L1 also seems to be the older fracture. The L3 seems to be the newer fracture, because if you see, there is evidence on the plain X-ray of bone healing happening between D12 and L1 anteriorly.
exactly.
So looking at the pain intensity, which is so severe, what will be your plan, Dr. Goregaonkar, now? So we have the X-ray, we have the blood reports, and we have the MRI. Patient is with severe pain, 9 on 10.
So the patient essentially has some kind of instability. Probably the fracture yet not united. It's in the process of union. Now, important thing is, even after 2 months, if the pain increases, you have to really search for what is the possibility. And so you must get a search for the multiple myeloma.
Okay.
Especially when 2 bodies are involved. And good that whole scanning of the spine is done. So no other lesion, but these two bodies involved definitely warrants to find out whether it's a multiple myeloma. Now, as far as treatment part is concerned, considering it's not a multiple myeloma, this patient has worsened over a period of 2 months. So some additional treatment is required, not only the anti-osteoporotic treatment. So I would think of doing some vertebroplasty for L1 and L3.
Okay. Okay.
Where basically the symptoms of pain will be taken care of.
Okay.
And then, of course, you investigate for the osteoporosis and start the treatment accordingly.
Yes, Dr. Deshmukh, what would you like to do at this situation in Aurangabad?
So I'm totally agreed with Dr. Goregaonkar, sir. It's almost a 2-month-old injury with definitive fracture at L1 and L3 level. As Dr. Ajay said, the pain is mainly focused at dorsal lumbar and lower lumbar region. So definitely at this point of time, I'd like to intervene surgically with vertebroplasty. That will be my first.
You will consider that. See, no one is wrong. Everyone can have a different opinion, and everyone is,
I would, Shailesh,
yes, Dr.
I would like to differ with both Dr. Deshmukh and Dr. Goregaonkar.
Okay.
And that is that this patient's primary problem is asthma, and she's on steroids, which has caused osteoporotic related fractures.
Okay.
Vertebroplasty, whatever you do, has a small risk of micro cement embolism.
Okay.
In you and me, if we get a micro cement embolism, it will not make a difference. It happens very frequently.
Yes.
But in a person whose respiratory function is already compromised,
yes,
a small microembolism with a vertebroplasty at 2 levels will push the patient over the edge, and then patient becomes ventilator dependent.
Understood.
When you talk about treating a fracture, it's not only about treating the fracture, you're treating the patient.
Yes.
So you have to understand the comorbidities.
Yes.
The other thing, patient is on blood thinners.
Yes.
You have to make sure that, because with vertebroplasty, there's no way you'll control. So the risk of epidural hematoma is very large.
Okay.
So
we have two opinions.
Yeah, Shailesh, I want to just ask a few more questions, if you permit.
Yes, Rajesh.
There have been 2 falls. So the duration from the second fall does not exceed 4 weeks, probably, Ajay?
Yes.
So usually most of us try to give a complete trial of conservative treatment. So I want from the panelists and the faculty their opinion about the duration that we wait for. And the second question is, in terms of suppose you want to intervene, is there any role for a standing X-ray to see any instability inside the bones or interosseous instability?
Yeah. So Rajesh, I was going to come to that. Now, in any patient, before I do vertebroplasty, especially when it is 2 months old, so you might get foxed. So one thing I do is I get a sitting X-ray and a lying down X-ray, or a standing X-ray and a lying down X-ray. And if there is significant mobility within the vertebral body, or at the superior disc, between the upper vertebra and the affected, fractured vertebra, if there's significant mobility, then, two things. One is, if the patient is really unfit and if he cannot survive a big surgery, you counsel the patient and the relative that I'll try something short. If it fails, I'll do something big. Because there is a possibility of cement leaking all over the place. Second thing is, and failure. And suppose there is no instability, then you straight away go ahead and do a vertebroplasty.
I want to ask
over a period of time, especially a dorsal lumbar junction, it might fail. It is a kyphosing, momentum there.
I think with this background, what happens is, in a bigger institution, you have a radiologist to talk to as to, this looks more of porotic, this looks more of neoplastic, this looks more of infective. But what happens in peripheral places, say like Ahmednagar, Jalna, Beed, they don't have an access to a radiologist firsthand. And what they do is a lot of tele-reporting. So I pulled up a review article as to, how to differentiate between a benign vertebral compression fracture and a malignant vertebral compression fracture. So these are a few points I will just run through.
Yes.
In benign vertebral compression fracture, you can see a normal posterior element signal, retropulse bony fragment, and an additional benign VCF, that is a vertebral compression fracture. But in a malignant, that is a neoplastic vertebral fracture, there will be an abnormal posterior element sign, number one. Number 2, there will be epidural or paravertebral soft tissue mass. And number 3, there will be expanded posterior vertebral contour, and there will be metastasis in other vertebra. These are 2-3 important points. Second important point is there will be in benign vertebral compression fracture, there will be preserved normal marrow signal. There will be regular margin. There will be fluid sign that we call the fluid sign that we see, and that is the indication for doing
Yes,
a
yes.
And as far as the malignant thing is concerned, there will be geographic replacement of normal marrow signal, irregular margins, increased enhancement related to adjacent vertebra.
Yeah, it's a good article. Ajay, we move on. Yes.
Yeah. One minute. I want to ask one thing.
Yes, Dr. Bhandari.
You said sitting X-ray and lying down X-ray. What we do is that full flexion X-ray and full extension X-ray, and these give you opening up of the vertebral body, and many times you can find intravertebral cleft. Intravertebral cleft is what is very pathognomonic of something like a non-union, you say, or a avascular necrosis, some people say. And
Okay.
That is a very valid thing, Dr. Bhandari. But what happens, a lot of these patients are so much in pain that to do flexion extension is not
It's difficult at times, yeah.
And therefore, a supine versus sitting X-ray, if you can manage to do it, very good.
Good, yeah,
It
absolutely.
is very helpful because it will show you the difference.
Yes.
Instability is within the bone or is the instability between the bones. You want to differentiate between intravertebral instability and intervertebral instability. And intravertebral instability, which is within the bone where the vertebral body opens up, can be treated well with bone cement, vertebroplasty. On the other hand, an intervertebral instability when the ligaments are ruptured requires formal surgery.
Yes, correct. Dr. Zawari, we noted your point.
Got a CT scan done to see the bony architecture, and there was a mild retropulse fragment, but which was just indenting the thecal sac, not compressing the thecal sac. We got his DEXA scan done, and the T-score was, minus 4.3 in the wrist and going up to -5 in the spine.
Dr. Bhave, will you do DEXA scan at this minute?
Yeah, actually, it won't change much our management because the goals of management is stabilizing the spine in minimally invasive way, because considering his asthma and osteoporosis. So for lower vertebra, we'll do vertebroplasty. Higher vertebra, we suggest to do vesselplasty, because everything I can do under local anesthesia. And with very good vitamin D correction followed by good anti-osteoporotic treatment.
Okay, perfect. There we are. The only person remaining is Priyesh. We would like to know what you will do it in Nagpur if the patient is there in front of you.
So with this patient, 2-level consecutive, like not consecutive, but 2-level fractures, and with the not failed, but he has tried conservative management, I'll go for a 2-level vertebroplasty in this patient as well as biopsy.
Okay.
Shailesh, before we go on to management, just simple question to Ajay primarily and maybe to Gautam and Arvind. We saw even the MRI was using the words like burst fracture, compression fracture. Now, these are all terminologies usually we use for traumatic fractures in a young adult without bony insufficiency, right? So can you enumerate in a sentence or two what is the right classification or description for the fractures with osteoporosis?
I think theoretically, if we see, the burst fracture is used when there is an involvement of middle column. So in this case, if you see, the middle column is involved, and probably the burst fracture classification they've used because you can see the posterior vertebral body is fractured and there is a retropulse fragment, and hence the word burst fracture is used. I agree with your comment that this sort of terminology is used in fractures in a younger population, but this is not the terminology which is used in osteoporotic fracture. But I think the radiologists go by the column classification, and the burst word was used because there was a middle column involvement. Yes?
I've seen this word terminology called senile burst fracture in this. These are low impact burst fractures. So in a few articles, these are described as senile burst fractures.
Yeah, there is a recent classification by the German Orthopedic and Trauma Group that's called as DGOU. They have classified osteoporotic fracture. This is a very recent 1 year back article, and it is picking up big time worldwide. It is sub-classified osteoporotic fracture into 5 types: OF1, 2, 3, 4, and 5.
Yeah. That is what I was going to say. Yeah.
Yes.
So according to me, Shailesh, All this is to gain self-importance. The only reason to classify, sub-classify it into anything more. What you need
but
to know
this is a
there are
widely
only two
accepted
things you need to know,
classification.
Sailesh, in terms of fracture. One is
because they
there
have
ligament injury or not, and the second thing is the posterior vertebral wall intact or not. Beyond that, you don't want to know because it doesn't aid in your treatment. So
because they have very
all these
clearly categorized which
classifications are
patient we should consider surgery, and it's a very big study. It is very, very important that we should, because till now there was no such classification for osteoporotic fractures. We always talked about traumatic fractures and T-leaks and things like that. This is one of the most beautiful fracture which classification which one can see, and it is not for anything. It is for every one of us practicing spine surgeons as well to understand there is a rationale for this.
There is an old fracture called as the Genant classification.
Yeah.
What you are describing, the German classification, is probably the 6th classification which is there on osteoporotic vertebral fractures. So it is not the new one. What I am trying to ask you is, how does it alter your treatment? Your treatment will depend if the patient has intravertebral instability, you are going to vertebroplasty. If it does not, then you are thinking of fixation. So how does it matter? You make your, why make your life, which is so simple, complex?
No, I agree with you, Dr. Zaveri, that classifications will confuse you, but the rationality of classification is useful. Anywhere I am not saying it is always a judgment where you should do what, it is not based on classification, but it gives a fair guideline.
Only thing is, I disagree with Ajay also that burst fracture is not applicable to osteoporotic vertebral fracture. In fact, it is very relevant. It has been clearly shown that patients who have a burst fracture or a posterior vertebral wall fracture, which is essentially a burst fracture, these patients have a much higher risk of delayed vertebral collapse and secondary neurologic deficit. So you need to know that, you need to look into that, and it is as applicable even today for osteoporotic vertebral fractures as it is for young fractures.
Can I suggest one thing?
Yes.
You, for easy remembering, rule of 40. If it is a 40% collapse and 40% intracanal or fragment coming in the canal, these are the both things you should consider for surgical treatment.
Okay, perfect.
That is a simplest thing you can remember.
There is to summarize, we'll go forward. Yeah, Dr. Goregaonkar, sir, you want to make any comment? Yeah, Dr. Goregaonkar.
Yeah, basically, I feel we are unnecessarily discussing on a classification. What we want to find out is what kind of treatment this patient needs, and not to put him in a which particular classification. Because classification keep coming, there will be one more classification which will be very good. But when you are treating the patient, there are very simple methods are there. One, this patient has essentially pain coming from the fractured vertebra, which you need to stabilize. So maybe the vertebroplasty. But if patient shows any ligamental posterior opening, which I could not see any of the views, if that is the thing, then it straight goes to the surgical fixation.
Okay.
Same time, at the same time, if there is a non-union, suggestive of some air shadow into the vertebral body, it is a non-union, and you must need a surgical intervention into it.
Okay, perfect. Yes, Ajay, tell us what you did.
Yeah, so now coming back to the case, we did a thorough workup. Myeloma was negative, and it was all boiled down to an osteoporotic vertebral compression fracture. So we offered vertebroplasty to this patient, but the family and the patient denied. They said, we don't want at the age of 80, we don't want a surgery. So I think vertebroplasty will be covered by Dr. Bhandari. So let's talk about the conservative management, the non-surgical. So when we start with the conservative management of an osteoporotic vertebral compression fracture, the first question is rest. So when we say to me, Sampurna Vishranti kya? Hello.
Yes, sir. Someone's
Hello.
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 Yeah. I can hear you, sir.
Yeah, we all should be muting our mics. Yes, Ajay, please.
So the first question is, when we say to me Vishranti kya, when we have to treat it non-surgically. So there are two things. One is an absolute bed rest, and there is a relative bed rest. So number one question to all the panelists would be, in our practice.
Hello.
Hello.
Yeah, I can hear you.
Talking, please.
what is the defined amount
Okay.
of bed rest that one follows? Number one.
Hello.
Whether it's an absolute bed rest or patient can go to the washroom, come back again,
Yeah, done.
go for his dinner, come back again. So how is it? The first question, Dr. Arvind Kulkarni. So what is your
No,
definition?
it's not.
Yes. So bed rest here is empirical. See, it depends. Most importantly, bed rest is for the initial pain alone. It is not in terms of nothing to do with the management. It is just for pain relief. So the patient is happy to get around, within limits of pain and do most of the activities, most of the day-to-day activities. Except for, in terms of counseling, you counsel the patient not to bend forwards, basically avoid flexion attitude. So within limits of pain and within limits of, this kind of sensibility, if the patient can carry on, patient is welcome to do most of the activities with a brace. But as I said, the initial rest is basically for pain relief. Patient's back is in spasm, patient is not able to move around.
Patient has severe pain, he should take rest, but as the pain comes down, he can start moving around. He can start going to the washroom, going for
what about as long as there is no neurological involvement.
Yeah, your take on bracing, Arvind?
So now there are few studies in North America, except where they don't even brace these patients. But our patients have poor muscle tone, etc., etc. So they are comfortable in braces. So I usually start with the ash brace.
Okay.
There are some patients who come, usually because these fractures occur at thoracolumbar junction, so T11 to L2 area. So I usually give a hyperextension brace. Over a period of time, some of them complain that they are not happy with the cross in the front. They're not happy. So then I convert it into a tailor's brace. But mostly my first choice would be a ash brace for a thoracolumbar osteoporotic compression fracture.
Okay, Vivek, what you will do?
So definitely, as Dr. Arvind said, rest is the first call. Usually 4 to 6 weeks of bed rest with guarded mobility. I'll ask them to go for get up from the bed for the basic purposes, not to involve in flexion activities. Once, along with that bracing, yes, ash brace is also my choice.
Okay.
But what I also found is they are more comfortable in tailor's brace.
Okay.
If the injury is in thoracolumbar level. Otherwise, in a lower lumbar level, corset is more than enough, I guess.
Yeah, message is clear, Ajay. Now we can go to the next. Yeah.
So
but many times patients are not very comfortable with tailor's brace. Many of them have returned that and said ash brace was more comfortable than tailor's.
It is as per the comfort of the patient.
Yeah, comfort. Yeah, as per the comfort, definitely.
Yes, Ajay, please.
So the next question is how frequently you call them for X-rays, for follow-up, and what is the end point that you see your healing? So that was the next point. So I think all of us would agree with the point that once we send the patient home, we call the patient back after a period of 3 weeks time, and we explain all the red flags to the patient, get an X-ray done and see that there is no further vertebral collapse.
Okay.
And then eventually we call the patient every 3 weekly for 3 consecutive visits and compare it with the previous X-ray and see for the bony healing. The next important point is, of course, there has to be supplementations, physiotherapy.
I will interrupt you here and I will ask you a question.
Yes.
Based on your full follow-up protocol.
Yes.
So suppose you call this patient in 3 weeks.
Yes.
Are you expecting some amount of collapse of the fracture or no?
Do expect some amount of collapse because that's
suppose
how
there is collapse. What are you going to do?
See, we have to take.
So why are you doing an X-ray? Is my question. Your endpoint is just pain relief.
See,
your endpoint is not a good-looking X-ray.
We are dealing with 2 fractures here.
If it shows progressive collapse, then you are not going to intervene if the patient does not have neurology.
Anyway, this patient, can I?
Yes, please.
If this patient, I generally call after 4 weeks or after 6 weeks, in fact, and tell patient relative to come and tell how the patient. What is important is if the pain is going down and down, the patient will start walking on its own. You don't need to tell him.
Okay.
Secondly, once the pain has less, unlikely that patient will have further neurological deficit or increase in the kyphosis. Now, little bit increase in the kyphosis is going to be there, but that doesn't matter as far as the vertebra is healing. So getting a repeated X-ray doesn't make any sense. Unless the patient start complaining.
Point well taken, but sometimes patient themselves want to do the X-ray. They want to see what's happening with my spine.
See, in this particular case, there are two fractures. First fracture is at the L1 level and the second fracture is at L3 level. So we need to monitor both the fractures. So I think initial assessment with serial X-rays would make sense.
Ajay, I feel that at
No, you don't manage. You don't manage with the X-ray.
Dynamic
don't manage
that 6 weeks are
with
more important.
Clinical scenario is more important.
Clinical scenario is most
Pain
important.
is a factor. Pain. You just rely on pain and you will get all the information. You don't keep taking X-rays and MRI for that.
Not
agreeable point.
X-rays and MRI is an excuse to do surgery.
Agreeable point, yeah, Dr. Goregaonkar, Dr. Zaveri, and we move on to the next, that we should give a good rest, and pain is the most important indicator. Yes, 6 weeks minimum, and then we call them back, or the relatives we call and just check how they are doing. If they are listening, then there is a chance that we should call them early, but otherwise 6 weeks is a good time to follow up.
Now,
I want to ask one thing. Yeah, what is the role of physiotherapy, as you are asking, when the patient is admitted? We usually give short-wave diathermy and interferential therapy, and that also really gives good relief from the pain. What is your experience?
Mainly for pain relief, but no limb, no axial skeleton, only limb mobility, that's it. There is not much of a role of...
Do you allow exercises? Do you allow exercises?
No, not at this stage.
No. Not at this stage.
Unless the patient is penless, you don't allow at all.
Absolutely.
Can I come? One of the contraindications for the short-wave diathermy is a severe osteoporosis.
Correct. Yes, sir. Dr. Karne, sir. Secretary of Orthopedic Association. Welcome, sir.
Can I add my 2 bits, since I have not spoken on non-operative treatment?
Yes.
Rest is never given. In an old patient, if you give rest, you are worsening the osteoporosis. The atrophy of muscle rapidly goes down. Within a week, they lose 30% of muscle mass. They lose coordination. They lose their confidence to walk. So you allow activities within limits of pain. Do not give rest.
Absolutely.
Number 2 is bracing. Bracing is useless. If you give a brace, these patients are frail old patients. The brace is heavier than the patient. Number 2, your ash brace pushes them into hyperextension. They have already got facet joint arthritis because of age. You put them in a ash brace, they will be highly uncomfortable. They will never wear the brace. Even a tailor's brace is very heavy, very cumbersome to use. I have not found patients to use it. The third thing, he has written radiological follow-up. I do not do radiological follow-up. Number 4, DEXA scan. I do not do DEXA scan.
Yeah, point well noted, Dr. Zaveri. Yeah,
I do not do DEXA scans. DEXA scans are useless. You know this patient has osteoporosis. You have to start the treatment. You know that even after your treatment, the value of DEXA scan is not going to dramatically change. Why are you wasting the patient's money? So give calcium, give vitamin D. I give physiotherapy to these patients. Start them on isometric exercises. Let them walk around a little bit. They will feel happy. They'll feel nice.
It's a very good interaction, and everyone is talking about their experience. I think Dr. Zaveri is pointing very important point that he will personally prefer no rest or less rest, immediate mobility, and bracing has no role in his practice. But at the same time, Dr. Arvind Kulkarni, Dr. Vivek Deshmukh prefers to have rest and bracing. Everyone is right. You know, it is a patient's life and your practice is important. No one is right or wrong in this. This is a very fair discussion. If we go to the next point, Ajay.
No, Shailesh, all that I am saying is all proven in literature. What you need to do is look up the literature. It's all rational and evidence-based.
No, the literature is for both the sides, Dr. Zaveri.
Dr. Gautam, we extensively researched this. And as far as the rest is concerned, the literature is divided. There are M-team number of papers who says that no rest is necessary only till pain control. There are N-team number of papers who say that a relative bed rest is necessary, and there are M-team number of patients who say that, you know, absolute bed rest is important and it does help.
Yes, Ajay, we understood the clear point. Yes.
Shailesh, one thing I want to add.
Yes.
For osteoporosis, we usually give IV zoledronic acid 1 dose and then follow it with injection.
We are coming to that. Bandari sir, we are coming to that. So now,
Ajay, tell me your prescription now, because we are running out of time. We have to discuss a lot of things. We just need
Shailesh,
a
only,
quick
I will make only one comment, Shailesh,
Yes, sir.
that we have to take the patient also into consideration. When if some papers are saying that the brace is useless, but if the patient is comfortable in the brace, we have to give the brace to the patient. So
Yes,
we
yes.
should go more importance to the patient's comfort rather than the brace. I mean, rather than the literature.
Okay. Point well noted, Dr. Karne, because what patient wants, that is literature is different, but what one-to-one when the patient comes to clinic or a hospital, to treat the patient as a whole, and some patients feel better with the brace, and it all depends on that. I agree with your point. Go to the next. Yes, Ajay.
I'll take 2 very important minutes, and that is the key of this thing is medical management. So when
Yes.
you talk about medical management, my first question is, do we treat it or do we take a help of an endocrinologist or a rheumatologist to treat osteoporosis? An open question to all the panelists.
In our
I
cities,
always take a help.
We should treat it.
I think you need to distinguish here, Ajay. You're also treating a fracture, which is prerogative
Correct.
of orthopedic and spine surgeons.
Correct.
But when it comes to treating a metabolic bone disease like osteoporosis, then you need to go into subcategories and probably investigate. But most of the people, if you feel you are, well versed with managing these things in your clinical scenario, there are no hard and fast rules, right? But that is my opinion again. And as far as osteoporotic medical management is concerned, that is the pertinent question, right?
Correct.
Right.
So yes, Dr. Arvind Kulkarni, I want your point, your take at your own institute, Bombay Hospital. Do you treat osteoporosis or you take help of an endocrinologist or a rheumatologist?
Yeah, see, 99% of the times it's me who treat the patient medically.
Okay.
It's not very difficult. It's quite straightforward.
Okay.
And unlike whatever, whether DEXA helps or not, what I do, I don't do a DEXA. I do a QCT. It gives a true value of volumetric because we have a QCT machine in a hospital.
Yeah, absolutely correct. Yeah.
Give sense of osteoporosis, and I'm happy to do that. I've seen so many reports I see all the time where the hip and the wrist shows something like -3, -3.5, and the spine is 0. And that is because of degenerative changes. So and same patient, if I get a QCT done, it's something in the range of -4.5 to -5.5.
Absolutely.
So, and I do this always before I start my treatment, because I need to know after 1 year what is going to happen. Okay, I need a baseline for which I'm going to treat. Okay, to reflect back upon. It's also necessary for research purposes. And second is, if the patient is not osteoporotic, so many times, you'll be surprised there is no osteoporosis at all. Why do you treat them with all anti-osteoporotic treatment? And the levels, so someone who is -1 will be different from someone who will be -3.5 and beyond. So you can't, the solution is not the same for all degrees of osteoporosis. It's very important to get your baseline, numbers right. Okay, once we
Perfect. Yeah.
At the time of fracture, when the patient comes to me, calcitonin nasal spray is a must. It works more as an analgesic. That's what the literature says.
Yes, I agree.
Okay.
Maximum up to 3 months.
Yeah. So
Usually after 1 month, we can stop it.
I usually ask them to exhaust 2 bottles. This is something which I learned from an endocrinologist. And then, regular calcium. So this is like, you can't start treating osteoporosis on the day of the lightning strikes. These patients should have developed their bone, quality, bone volume, bone density over the period of during their adolescence and adult life, adult life. So you cannot treat them in 1 day. So you have to counsel them. Counseling is very, very important to take all this regularly.
Yes.
See if the vitamin
D levels are low. Thank you, Arvind. Thank you. We will have to go to the prescription. Ajay, we would like to know your prescription for this patient now, and then we will have to sum up this case.
Yeah, so the prescription that we gave for this patient was, we started him on analgesic in the form of tablet Ultracet. We gave him an antacid. We started him on calcium and vitamin D supplementation. And we started this patient on injection denosumab because his creatinine levels were very high and his PTH level was very high. So we initially started this patient on good amount of, because that's a secondary hyperparathyroidism that patient has got. So we've started him on good amount of calcium and started him on injection denosumab. That's anti-resorptive agent, 1 injection every 6 months. And that has to go on. So that's the prescription that we started for this patient.
Shailesh, I would like to add that routine, what I have heard recently, that you give 1 dose of IV zoledronic acid followed by injection teriparatide for minimum 1 to 2 years.
That's a sandwich therapy, but in this particular case,
Point well. Just a word of caution here, Ajay.
Yes.
You said you started patient with ultrasec. These elderly patients already have giddiness and falls. With
Correct.
ultraset, a lot of them get more giddiness, and you have to be very careful.
Yeah. So what
I
we
give
do was,
half dose of ultraset semi, if at all, twice a day. Be
So we
very careful giving all these opioid or non-opioid analgesics because they can increase giddiness. The second thing you must think about is relieving their constipation. Because of pain,
Exactly.
they always have constipation which troubles them. Put them on laxatives.
Yes,
Because the
perfect.
ultraset
Very
reduces
point
the
well taken. Yes,
ultraset reduces the intestinal mobility also, and so it adds to the constipation. Third
Correct.
thing is what sort of calcium you are using. If you are using the calcium carbonate, that again adds to the constipation. So
Correct.
these things has to be taken into consideration.
Absolutely points well
Yeah,
taken.
well noted and excellent case. Ajay, I would really appreciate all of you have given excellent your inputs as per the literature and your experience. I would like Rajesh to sum up the case and we go on to the next case of spinal fracture. Yes, Rajesh.
Right. So, excellent case, Ajay, to tell us about what are the issues in the management of osteoporotic fractures. First and foremost, we need to remember that a fracture is a fracture, but there is a difference between a young adult male or young adult patient with good bone mass and insufficiency osteoporotic fractures. The things to see primarily when the patient comes with a fracture is an X-ray. Also try to judge if there are any predictors of further collapse, kyphosis, retropus fragments, or advancing neurology. The conservative management primarily is to control the pain. Most of us, all of us, primarily treat this conservatively. Only those patients which have progressive collapse, persistent pain, going forward to kyphotic deformity, they are. So none of us is primarily considering kyphoplasty or vertebroplasty or any kind of fixation. But the distinguishing feature here between osteoporotic fracture and a normal fracture is instabilities. Inability of the fracture to heal like a normal adult bone. Right? So that is what we are talking about is the interosseous or interosseous instability, non-union or persistence of pain. So the conservative treatment primarily depends on pain. Let the pain dictate whether you use a brace, where how much raise the patient is going to take, what kind of medications you're going to give, when you're going to mobilize the patient. Being an old, most of these patients are senile, right? So being old, they have higher chances of chest complications, other complications. So physiotherapy need not mean exercises only for the spine. Keep their limbs mobile, avoid complications. As soon as the pain is less, ambulate them and distinguish your medical management of the pain and management of the osteoporosis. And further cases will tell you about the fracture management as well. Is that okay, Shailesh? We can go for
Yeah, perfect. Very well sum up, Rajesh. And because we have to take the patient as a whole and how the patient is presented, what type of medical issues, comorbidities he has, all these things we have to take it in consideration to treat it, and definitely help will be taken from endocrinologist if it is a very severe osteoporosis or you think there are some medical issues. Otherwise, routinely we as orthopedic surgeons, we definitely can treat osteoporotic fractures very yes, Dr. Bhandari, over to you.
Yeah, thank you, Shailesh. Good evening to you all. As we are saying that this is a webinar which is aimed at the peripheral surgeons and general orthopedic surgeons like me who do a lot of work in spine. These osteoporotic vertebral compression fractures, really about 60 to 70% definitely can be treated conservatively, but about 30 to 40% do require treatment. And I have over the years, I'm doing it for nearly 15, 16 years, and more than 350 cases. I have come to a conclusion that many people are really afraid to do this vertebroplasty. And really in most of the centers in Solapur, I have to go and do it. I have many times encouraged them to do this. So I thought that I will share a few practical tips to this do this vertebroplasty by a common general orthopedic. The spine surgeons are, of course, the cakewalk for them. But for the common orthopedic surgeons, I would like to share a few.
Yes, sir.
So this is my first case. Again, this was treated by one of my colleagues. This was a 64-year female. She had a trivial trauma about 1 month back before presenting to that my colleague. She had very severe pains in the dorsolumbar junction with what we call as a typical accordion phenomenon, where the patient gets pain on trying to sit up from the lying down position and again gets pain when she is trying to lie down from a sitting position. So typical accordion phenomenon, severe disabling catch in back, what we call. She was a known case of hypertension, but there was no diabetes mellitus or no cardiac problems as such. as most of them do in such a scenario, she was treated conservatively by analgesics and bed rest and braces by my colleague. And then she presented about 3 to 4 weeks later with worsening pains. And here you can see that the D11 as well as D12, two vertebrae are collapsed. The D11 vertebra is nearly a vertebra plana. And if you have seen in the previous X-ray, the red arrow shows that there is an intravertebral cleft. Even in 1 month back, she had an intravertebral cleft in D11 vertebra. And that vertebra has now showing a lot of collapse. So he called me after doing all control of comorbidities and investigations, which we have discussed just now. And we decided to go for a 2-level vertebroplasty. Now, I will ask everybody whether MRI is always essential. I do advise them, but sometimes when I go to many places in Sholapur, the MRI is not there. And they call me directly for surgery. But many times I have not found it very essential, though in my own setup.
MRI is very essential.
It is essential.
MRI you shouldn't do. You may
It
be
is-
an occult fracture, which may be the cause of pain. This may be a healed fracture. You will be surprised.
Maybe instability.
Yeah.
MRI is mandatory.
Sure.
Dr. Bhandari, we will go to the next point because MRI, as Arvind said, is mandatory. Whatever, if we are doing any procedure, it is always safer. Yeah, we'll go to the next point. Yes, please. Yeah.
No, yeah, I do advise, but I just wanted to open. Okay.
Yeah.
So now just everybody knows what is percutaneous vertebroplasty. It is involves the structural reinforcement of a fractured or collapsed vertebral body.
I think Dr. Bhandari, this is not supposed to be a lecture, tutorial, teaching this thing. I think Shailesh has explained. So we will fall short of time. Sorry to be rude. So just go forward and put pointed questions to such eminent faculty. Use them through the opinion. Everybody knows vertebroplasty.
Because I really think that general orthopedic surgeons should have some idea about this. That's why I'm sharing the tips.
They will ask you questions, sir.
Okay, so I always give a hyperextension position in with 2 transverse bolsters under chest and pelvis, because this helps in positional kyphosis correction. Because as we see in this dynamic X-rays, in extension, the vertebra is opening up nicely. So if you can get that position during vertebroplasty, that is always good. Secondly, I do most of my cases nearly, except 1 or 2 cases, nearly more than 300 cases I have done under local anesthesia. Because what I find is that it is safe at this age, and it also helps with verbal feedback from the patient. And one more important thing which I want to say is that I use 2 millimeter guide wires for transpedicular entry rather than direct entry by thick J needle, because the smaller diameter, there are less chances of neural complications. Secondly, if needed, many times this is a very important advantage, that if needed, if you see that in the lateral view you are going more cephalad or caudal, you can change the track very easily with a guide wire, but which you cannot do with a larger diameter needle. And of course, a sharp tip. So many times in osteoporotic vertebrae, you can just push it by tactile feel. And one more useful tip which I am doing for last 7-8 years is bipedicular entry. I am doing bipedicular entry because you can see that by injecting normal saline through one needle, you can definitely wash out the debris from the vertebra, and you can create a space for easy injection of cement. Also, the second needle acts as a vent. So uniform spread is possible without force. And in many cases, if there is really no intravertebral cleft, then there may be unilateral spread with one needle. So second needle can help in spreading. And of course, in cases of doubtful diagnosis, core biopsy can help by pushing the needle through the pathological area and then getting a big core of tissue for getting tissue diagnosis. So with these tips, I will go further to that case of 2-level it is D11, D12, not D12, D11, sorry. So with hyperextension position, you can see that the opening up of that vertebra plana also is very well seen of that D11 vertebra. And then the localization is done first in lateral view, and then in AP view, I have passed these 2 guide wires in the D11 vertebra first. And then later on, I have passed next 2 guide wires in D12 vertebra, and these are the AP view. Then I turn the C-arm to the lateral view. And now if I find that the direction of the guide wires is not good, then many times I can easily change the direction of the guide wires. So now these are the 4 guide wires with a needle being passed on the one of the guide wires. And this is the picture where the 4 needles are there in 4, both the vertebrae bipedicular entry. And now you can see that in D11, by pushing normal saline through one window, one needle, you can really get a good clearing of the debris from the second needle. And now it is more or less clear. Now I am doing that same thing, and in D12 vertebra. Now you can see that the patient is having more pain in D12. She's really crying out when I'm trying to push the saline through that. So really we think that D11 is the thing, but D12 was more painful than D11. Now, again, one more tip that we are all the time worried about the cement leakage. So I always push a radio opaque dye or omnipack through one of the needles, check it under the C-arm images, and then if needed, I wash it off with normal saline. If there's some leakage seen posteriorly, I can inject a small quantity of cement first to really seal that leakage. And then after about 10 minutes, remaining cement can be injected so that there will not be leakage posteriorly and cosmological. So any other view about this?
Yeah, they are very well documented and explained, sir. You are doing practice in Solapur, and it is a very well developed city. You are doing it in a very right way and doing it in a local anesthesia. It's a very important that we have to take all the possible precautions. Some people prefer to use some kind of a gel foam embolization to prevent that nerve endings, to prevent that leakage of cement. But otherwise, it's not that it is a must. Dye is very important. Always check that when there is you always check with the dye how you are before you cement the vertebral body. But I think overall it's a very systematical approach which you have shown. I would like Dr. Bhave to comment and then we go to the next level.
Yeah, looking at this, it appears that the first fracture which has converted into a cleft, and it has got adjacent level fracture which is a fresh fracture, and that has been correlated well in this video that patient had more pain in the lower fracture. So that is why Arvind Kulkarni had pointed out that you should always take MRI to find which one is a fresh fracture and which is a secondary fracture. So I think D12 was a fresh fracture, and the Kuhl's disease where it was a old fracture, and that was causing kyphosis. So if possible, treat both the fractures simultaneously. I always take biopsy from the Kuhl's lesion because I had surprises of renal amyloidosis, CA prostate, CA thyroid, CA stomach, CA lung. So all possibilities we had with this. So before washing with the other, saline, I always aspirate it, send it for pathological this thing. Like FNAC, if the availability is there, you do FNAC, find out you are not dealing with infection, and then only go ahead with further things.
Yeah. From this presentation, we have come across that most important things are important. That first is level marking is very important. MRI is mandatory. We should never do it without MRI. That's one important finding which we have gathered here. Yes.
Going ahead, the film material which I usually use is simple low viscosity bone cement. That is the Stryker Surgical Simplex 20 gram half dose cement which I use usually. And most important thing which I have found is that the pre-cooling of the cement polymer powder and monomer ampule is keeping by refrigerator overnight at 4 degrees centigrade. And if you are not really getting that time, you can just keep that cement monomer ampule in freezer for half an hour, and that is also sufficient. It increases your working time so nicely that you can work very slowly and leisurely rather than doing it without that pre-cooling of the cement. And one more, actually articles I found out that these two gentlemen, Chavali and Lai, they are keeping their pre-mixed cement syringes in an ice bath. And they have shown that the cement setting time increases to 150 to 120 minutes. If you're doing at 2 level, 3 level at one sitting, you can really take 40 gram cement and keep the cement syringe in cold ice bath so that you can use them further. And one more important thing is that I add a sterile barium sulfate powder to that, about half a teaspoonful of barium sulfate powder to that cement polymer. And then after mixing that, I add the monomer. it increases the radio opacity and is very useful in monitoring the injection of the cement during, especially for the leakages.
Thank you for a wonderful demonstration, Dr. Bhandari. And vertebral cement helps by stabilizing the vertebral body, the fracture, and it helps by thermocoagulation effect into the vertebral body. The nerve endings which are painful, causing the pain, really gets stabilized, thermocoagulated, and we get excellent pain relief. And one of the very nice demonstration, Dr. Bhandari, I would like to...
Dr. Bhandari, are you keeping the cement fills in? The cement is mixed and then it is kept in the freeze?
No.
What?
Cement box, the polymer and the monomer.
Pre-filled cement syringe.
Yeah, not mixed cement, definitely. And the important one more thing which I have learned is that you use 1 ml tuberculin syringes which are filled from a 5 ml syringe, and then they are injected, they are filled up, 1 ml syringes are filled up from a 5 ml syringe. And then your assistant gives you one after another, and you can inject very easily without much force with that 1 ml syringe.
Yeah, perfect.
Found useful for minimizing cement leakage is that injecting Omnipack, slow injection with bipedical entry, constant CR monitoring and verbal feedback, and kyphoplasting affording patients. And this is the patient at the end of the procedure with just 4 small marks. And this is the post-operative, immediate post-operative X-ray. And this is the patient after 4 hours. She's walking comfortably. She was in horrible pain, really. But she was so comfortable in about 2 to 4 hours that we could do this. So
excellent demonstration, Bhandari sir. We would like just a faculty quickly, only 2 questions. How much cement normally you prefer in your practice? Is it a small quantity, 1 to 3 cc or more?
5 ml. 3 to 5 ml, and I push with
your experience. Yes, Dr. Gautam Zaveri.
Yeah, tell me.
How much cement you normally prefer in your routine practice?
So the bare minimum you want is about 1.5 cc is the bare minimum.
Okay. Yes, perfect. Okay, Dr. Goregaonkar.
About 2 to 3 ml, maximum 3.
Okay.
You don't want to inject.
I think the overall consensus is 2 to 3. Yes, Dr. Kothari, Ajay.
Yes.
Yes.
It depends upon the indication. So sometimes you inject for only bone edema, okay, and sometimes you inject for cleft. So when it is just bone edema, you know, as Gautam said, it's about 1.5 2 cc. Don't push it. There's no wall. There's no void to be filled. You just have to. That is for thermocoagulation.
Okay.
And when there is a cleft, maybe 3 to 4 cc's to fill that.
Alvin, what I want to say is that I'm all the time monitoring, and till the time the patient.
No, the indications are different in osteoporosis itself. Sometimes there is no cleft. It is bone edema, which you are, it is just hypointense on T1 and the patient is painful.
Yeah, agreeable. Yeah, Dr. Ajay.
I want to say that in this level, you can see that about 2 to 3 ml in the upper vertebra, while about 4 ml in the lower vertebra. So it all depends on the indication.
1.5 to 5 cc anywhere in between is acceptable. Do not try to put too much cement. You will make the bone so stiff. If you go beyond 5.5 cc, the vertebra becomes very stiff, and then the adjacent vertebra, adjacent to the where your vertebral plasty has been done, tends to develop an osteoporotic fracture because you made this level. So,
yes,
sir, Dr. Bhandari, what you are doing is absolutely right. 3 to 5 cc is perfect.
Yeah.
Yes,
so,
Ajay.
Just I'll summarize. Because I will not put the other cases, I'll just summarize what I wanted to say, and then we'll have a discussion. So a few important tips which
we're going to go for the next case because
I'll the other cases because one was for secondaries with a core biopsy, and third case was really this case was with a intravertebral cleft.
I think we can see if we get time. We definitely would love to see. But because of time constraint, we'll have to go because Dr. Priyesh, and then we have a lot of discussions again going on, sir.
Yeah.
Wonderful case demonstration by you, and we are really enlightened. Just wanted to ask Ajay last opinion about you, and then we go to Priyesh's next case.
I think it depends upon the indication. If there is a pseudarthrotic cleft in osteoporotic vertebral fracture, then we can inject up to 3 to 5 ml very easily. But if there is no cleft, there is no void where we have to fill it up, then I think 1 to 2 ml suffices. So it definitely depends upon the indication for which we are doing.
But one thing I would like to add, Shailesh, last is that intravertebral cleft, which opens up on the hyperextension X-ray, is the best indication for these patients will get immediate very good relief, and they will accommodate around 3 to 5 ml and with a good correction of kyphosis also with vertebroplasty.
Dr. Bhandari, that is a controversial statement you are making. They do get pain relief, but a lot of patients with a cleft have an anterior wall which is defective. If you put cement there, the cement can leak through the anterior wall into the chest. Okay, so therefore you have to be careful there. Number two.
Yeah, point very well taken, Dr.
more
Zaveri.
And
Only one last point I wanted to
more
ask
it
Dr. Vivek
opens-
Deshmukh.
1 minute
Yes,
silence.
Yeah,
You are talking about the Kummel's lesion with pseudoarthrosis. Let us be very clear here that the more the pseudoarthrotic cleft opens up, the more cement you put, the more is the risk of subsequent secondary collapse of the same vertebra. So don't think that you can put more and that this is a controversial indication. If you look at literature today, Kummel's lesion is now becoming more and more treated with surgery than with arthroplasty.
Yeah, then you have to add the.
So finally, for the purpose, for the benefit of all the young surgeons who are attending, can you just summarize in your clinical practice today, what is the exact indication for vertebroplasty? Gautam, Arvind, Bhavesh sir, Vaigurya sir.
So according to me, vertebroplasty is not a panacea. Majority of osteoporotic vertebral fractures will heal on their own. There is a study of the natural history of osteoporotic vertebral fractures, which shows that almost 80% of vertebral fractures will heal with or without collapse over a period of 6 weeks. And that 80% of patients will get pain relief within 6 weeks of the fracture. These patients should be treated non-operatively. Then you come across a group of patients who are not responding. So they may have a collapse, but they are asymptomatic. There is no need to do anything. The indication for vertebroplasty is a painful fracture, which is more than 4 to 6 weeks, and patient is having still got a lot of instability related pain. That is the indication for vertebroplasty. What is more important?
Okay, we go to Dr. Bhave. Yeah.
Yeah, the latest paper to April 2020 also says the patient who are hospitalized with severe pain, then they are also good indication to do a vertebroplasty. That is in addition. I'm talking of May.
Neurologic deficit. You do not operate on neurologic deficits with a vertebroplasty. Number 3.
No, then you have to open surgery.
Yeah. So
if there's neurological deficit, definitely open surgery.
We are talking of this indication is only for fractures without neurological deficit.
Yes, let me just complete the contraindications. Number 3, if there is a large anterior wall defect from which the cement can leak, don't do it. Number 4, relative contraindication is if there is a significant posterior wall burst fracture and a fresh fracture you're doing it in, there is a leakage posteriorly. Number 5 was a condition like the first case you showed where there is already respiratory compromise. Number 6, presence of pre-existing pyogenic infection of the vertebral body. Number 7, if there is a large void, suppose the intravertebral void, when you, as Dr. Bhandari mentioned, that when he keeps the patient prone, the vertebra opens up so that he can put more cement. But the more you open it up, the more cement you put, the more is the risk of subsequent fracture again. And therefore, if the void on posterior opening up on prone position is very large, which you should anticipate on your flexion extension X-rays, then do not do a vertebroplasty. So the contraindications are far more than the indications.
Yeah, about the canal compromise, Gautam, retropus fragment canal compromise percentage-wise, when will you accept?
So if there is a canal compromise by itself is not a contraindication to doing vertebroplasty. If the patient has a neurologic deficit secondary to it, you don't do a vertebroplasty.
Yeah.
If there is
in certain cases, it is mentioned that more than 50 to 60%, then it becomes extremely risky to do because there is a chance of further.
Yeah. So suppose now, if most of these patients, if you are going to, as I said, one of the relative contraindications was retropulsion of bone, which means canal compromise. So that depends on your assessment whether you can do it safely. when I do a vertebroplasty, I make sure no cement goes into the posterior 1/3 of the vertebral body. As long as you are able to manage that, the risk is low.
But the Omnipack injection really helps you a lot to know where the cement is possibly going to leak. And of course, my purpose was to really initiate peripheral orthopedic surgeons to undertake this procedure, because who are doing the spine work a lot, but they are still afraid of doing it, which is my observation.
Secondary using Omnipack or some amount of radiopaque dye to see the spread within the vertebra is extremely useful. I do it all the time. You don't want to see only the leakage into the epidural space. You want to see its leakage into the vertebral veins and into the vessels, because that will also show you that
that will also come.
So yes, it is a very useful technique.
So
it's a very useful technique, but we have to be very careful at the same time. There are devastating complications of vertebroplasty which we can come across. Pulmonary embolism.
One question can I ask?
Yeah, and leakage of cement anterior or into the canal, and weakness, paraplegia. We have experience of this patient referred to us, and so we have to be very careful. It is not a very simple procedure, you know. And,
all the time.
Absolutely.
So, injecting is very important.
My question is, now when we are on vertebroplasty, esteemed faculties with us, their experience with kyphoplasty, indications and the percentage use, and how you decide like when to go for vertebroplasty and when to go for kyphoplasty.
So Ajay, I don't do kyphoplasty because all the theoretical advantages of kyphoplasty I can attain by just hyperextending the table at the site of the fracture.
Okay. I don't do kyphoplasty either.
Plus, you know, the cost.
The other disadvantage of kyphoplasty is that kyphoplasty requires general anesthesia ideally, which these patients are not very fit for general anesthesia. So that is another point. And the other point is, in kyphoplasty, once you create the void, the amount of cement you are injecting is so large that the amount of cement is more than the amount of bone within that particular vertebra. We have seen that the bone actually collapses and the cement does not interdigitate with the bone. The cement just remains there like a blob without integrating with bone. So I am actually strongly against the procedure of balloon kyphoplasty.
Can I ask a small question?
Yeah.
I'd like to add one thing, that recent meta-analysis published in IJO 2015 of about 711 studies. They have gone and selected 11 or 12 studies. They have said that pain relief, then adjacent level fractures, everything is equal in vertebroplasty and kyphoplasty. The only advantage of kyphoplasty they found is that correction of anterior vertebral body height and kyphosis correction, which is not very important here.
Vertebral height restoration with kyphoplasty is a big debate, and I totally disagree that it really restores the vertebral body height.
Yeah. Can I ask a small question, please?
I would prefer, instead of kyphoplasty, vesselplasty, you have a safe implant done under local anesthesia, same time of vertebroplasty and more safety. And that implant remains with you lifelong. So there is no question of additional percutaneous fixations. And that also, if you want, still you can go on adding percutaneous fixations also. In
last question, please. Sharish sir.
So,
yes.
So every time it is like unipedicular or bipedicular, like what everybody prefers.
Yeah, that's what.
There is no role for bipedicular.
Actually, the result shows that even unipedicular has the same.
Yeah.
This literature is not new. This literature is over 15 years old. That unipedicular injection is proven to be as good as
bipedicular.
There is no advantage.
Yeah,
However,
excellent discussions all, and I think unipedicular is as good as bipedicular. You have to be very careful and safe when we do a vertebroplasty. Patient selection is the key. Average 4 to 6 weeks time. We should prefer to wait for minimum time for giving this chance of vertebroplasty in patients, and at the most important, physical assessment and medical comorbidities play a big role in vertebroplasty. I think we sum up with a good case of Dr. Bhandari, and we go to the next case with Dr. Priyesh. Will you please share your screen? Dr. Bhandari, you'll have to close your share.
Yeah, I already closed it.
Yeah.
I already closed it.
And this is all a very healthy discussion, because we are trying to cover up most of the things in 2 hours, which is a very Herculean task. non-operative, vertebroplasty and surgical, and then we have rapid fire cases quickly in 10-20 minutes. Yeah. Yes, Priyesh.
Yeah. So good evening, everyone. So this is a now third case in the scenario. This is a 70 years old lady. She has a history of fall and got a L4 compression fracture on the X-ray, which you can see like it's the fracture over here. So as we has discussed with Ajay's case also, this early fracture, we try a conservative management. We treated her with bed rest, brace plus minus, as well as the medications, analgesics, calcium, vitamin D. So again, at 1 month follow-up, she don't have any pain relief. She was advised again conservative treatment. At 2 months, still she don't have pain relief. So my question is like at this stage, at simple fall with a fracture, just a superior inflated fracture, should we go for the MRI scan?
Yes. Yes.
Definitely, yes. Definitely.
Yes.
Definitely, yes.
You
So
can
there
see
is
the
nobody who
superior
says no.
end plate eroding whatever X-rays you are projecting. You can
Okay.
see the superior end plate collapsing. The lordosis is getting altered. That means patient is getting flat lordosis. So you have to check for instability, early instability.
So again, the thing is, if it is happening at an unusual site, so
Or
usually
whether she is getting
osteoporotic
infection,
fractures
that is another
happen
thing.
at
This
lumbar region. If it is occurring at an unusual site, which is not very common, you should be far more suspicious in terms of carrying out your MRI as well as your blood investigation.
I think in today's era, MRI is no longer a treatment of investigation of luxury. It's I think a very basic.
So this is her MRI scan. It shows a L4 compression fracture with, as I told, the superior end plate is getting sort of maybe not destroyed, but yeah, you can see the defect over here. So would you intervene further at this stage, like?
Yes, if 2 months have passed, you have to intervene. How long you are going to keep this lady in bed? Because she will develop secondary problems like DVT, urinary infection, and chest infection.
So we did some blood tests. Yeah. Yes, please.
At the end of 2 months, was she comfortable or still painless?
No,
Was
she's
the-
still
in pain. That is why he's
she's in
presenting.
pain. She's in pain. She's not able to move. So at presentation, like, yeah.
One more thing you should ask in
2.5 months.
patients is you should check if they have any history of neurogenic claudication. This
So
is
she's non-walker. Actually, she's like a non-walker because of the pain. She hardly walks.
No, prior to this, or now if she has any radiating pain, because these patients have, subclinical stenosis prior to at L4, 5, L3, 4, etc. And, the superior end plate fracture aggravates the symptoms. So this is, and that changes the line of management totally.
Yeah, yeah.
So
you need MRI
to take that history. Axial sections you have?
Yeah, I will have. So at this stage, stage she presented to me like 2 months, 3 months trial of conservative treatment. She was in terrible pain, and now I did X-ray again, which shows it's a complete collapse now.
Must get
Complete
a
collapse of L4.
You should get the
She's very, very painful in the bed now. 3 months conservative.
Can you show the axial sections?
Yes, MRI तो कर यार, MRI तो दिखा axial view.
MRI हो गया ना, MRI. Yeah. So the fracture has progressed now.
No, the axial views.
Axial view of MRI.
Axial I might have, yeah. I just put it over here. But there was no spinal canal stenosis as such.
No, the other thing is in the axial sections, if you'll get to see the posterior elements, if they are also affected or not.
Yeah, so
that will help you differentiate in a small way whether it is pathological or trauma related.
There is a fluid.
Describe what it was.
There's a fluid. Yeah, there's a fluid left in L4.
Fluid.
So it looks like
more osteoporotic.
More osteoporotic, like since 3 months.
Normal.
And then now spinal graph also shows like there are a couple of injuries around.
Inferior end plate is also fractured.
Yeah, is also
yes.
fractured.
So L5 inferior plate, it shows a marrow edema over here. L4 is completely collapsed now. Some changes in a couple of vertebrae. So we require to investigate in the form of bloods, maybe, yeah, because still we can think it is multiple myeloma, can think it is sort of metastasis. So clinically, she don't have any history of cancer or any sort of metastasis around. Her DEXA scan we did, it was showing osteoporosis. Her calcium, we always send calcium alkaline phosphatase as well as myeloma profile, and it was negative. So Now the management protocols for this type of yeah. So 3 weeks old patient, a complete collapse, very painful in the bed, no leg symptoms, neurology is fine as blood and bowel. So should we 3 months? Yeah, 3 months from the
Yeah,
start.
we should
Vertebral
try to
has
find
collapsed
out the
completely.
cause. We must find out the cause. Because if it is a secondary or some other thing other than a osteoporosis, and you keep treating like osteoporotic fracture, then patient may be in a more trouble.
So just the blood shows it's
No,
normal.
biopsy,
It's not multiple
biopsy.
myeloma or any infection.
If you get a myeloma present in a blood, fine. But otherwise, if it is negative, you should get the biopsy done to find out what is happening there. Why so much pain? Why L4 vertebra involved? Because if you overlook this, you may miss out the important pathology.
So the MRI shows that there is no sort of any mass over there or any sort of a destruction of vertebra. So it is delayed case of osteoporotic fracture with vertebra plana and with severe instability type of pain.
The presence of a fluid sign like that indicates it's a benign osteoporotic fracture and not a malignant involvement or infection over there.
Is there any role of PET scan into this to find out whether there are mates or something?
We did a sonography, yeah, PET scan. The MRI picture doesn't show it as a sort of metastatic lesion. No destruction of the valves or no involvement of any soft tissue mass like that.
The fact that she has had multiple fractures of varying ages. There are old L1, 2, 3 fractures which are healed, and there is an L5 which is a compression inferior end plate fracture and a fluid signal, means this is osteoporotic and this is not malignant or infective.
So it is a delayed presentation now. Yeah, 3 months old. We tried conservative. At this stage, we should intervene, or should we still?
Yes, you should intervene.
You should intervene.
Definitely intervene.
Offer a surgical solution to her.
So should we try like a vertebroplasty or kyphoplasty type of solution?
Surgical solution can be a vertebroplasty, kyphoplasty, or instrumentation, depending on in what you feel. But since the MRI has shown a fluid signal, a vertebroplasty will still work. But as Arvind has been telling you, we need to see the actual scans. Often these patients, when they have the burst fracture of the posterior wall, gets retropulsed and they have a secondary spinal canal stenosis at that level. So that will help us. What the MRI actual scans will tell you whether you have to do a surgery, formal, or a vertebroplasty will be enough.
So I prefer to do surgical intervention in this case.
What is the age of the patient?
70 years. So she's osteoporotic. She was having, as Dr. Zaveri told, she was this looks sort of osteoporotic to us. Even L5 is now getting in-plate changes as well as marrow edema. So I thought it's better if there is rather than going for the vertebroplasty. And she has typical instability type of pain. When she get up, she's in terrible pain. She's non-walker for 3 months now. So considering this, I used this cement augmented screw, as well as did a biopsy and biopsy of L4, as well as the as inside I put some cement also over there. So as the BMD scan was very low, she was 3.1 in DEXA scan. I prefer to use this cement augmented screw to have a greater purchase. With the positioning, I got this lordosis, as Dr. Bhave told, the lordosis was lost. She was flat back. We created a lordosis in her. And then at the same time, she don't require any sort of decompression posteriorly. So I didn't do a laminectomy. I just put a bone graft over there posteriorly.
Congratulations on a wonderful result.
Good job.
But my question is, you mentioned that because DEXA scan was minus 3.1, I decided to do cement augmented screws. So what is your threshold? Is it minus 2.5? Is it minus 1.5? Is it minus 1? When do you decide I want to use cement augmented screws and plain screws will not do?
But it's a documented osteoporosis, but rather than depending on the BMD scan, I will more dependent on the MRI scan, which shows like the lower vertebra is also now collapsing and it will require some sort of augmentation.
I think the best
What about worrying now that the adjacent level will fracture, the one which is already slightly collapsed at L2, because you have created a stiff segment below that, there is a possibility L2 will now fracture.
So yeah, this.
Why didn't you do a vertebroplasty?
My suggestion is same. Prophylactic vertebroplasty is essential because he will come with adjacent fracture in the next few days, or her back pain will remain persistent, and they will blame for your surgery, however good you have done.
So yeah, I thought like
So you will do a
L3
preventive
was
vertebroplasty, Dr. Bhave, at the level above?
Yeah, one level above, because it is a old fracture already, and here made it so rigid because of in the view of correcting the lordosis.
Okay.
So it is going to get overload and it is going to collapse.
Okay. So you will definitely prefer a higher level.
Yeah, if you are doing such an extensive surgery, you can just very well put one needle there and put another 2 cc of cement, 2 to 3.
Okay. Yeah, Dr. Goregaonkar, will you prefer to do a adjacent segment vertebroplasty in this case?
No, not at all. What I'm doing is,
so it is already a old fracture.
No, one higher one.
It is not fracture. There is no marrow edema too.
No, it is an old fracture. So marrow edema won't be there on MRI.
I don't think that is giving trouble. What trouble is there only because of the L4.
Okay.
And instead of cement, I feel you should put a bone graft and pack it.
You prefer a bone graft. Okay, that's a good one. Okay. Yes, Vivek, what you will do in Aurangabad?
Sir, I tried initially. I'll try definitely vertebroplasty in this case.
Okay.
At both levels.
Okay.
Yeah.
Ajay?
I think I need to study that higher level fracture properly. I need to see the stir sequences because there's just one T2 sagittal that we have. So if it shows that it's an old fracture and it's very well sclerotic ends, I'll disregard it and I'll just do what Prius did. But if
Ajay, try to understand. If you see that whatever the upper vertebra above the top screw, the end plate is already collapsed on the MRI or the post-operative X-ray.
N number of fractures, Dr. Arvind.
These are like
how far you will go?
I don't think you are.
Whatever it is old, it is because of osteoporosis.
It is an old fracture.
I think you have to treat osteoporosis because you'll have these wedge fractures at every alternate levels. So how far you will go?
What Dr. Bhave is telling you is not the problem that L2 is painful right now. What he is trying to say is by making L3 to L5 a rigid construct, you are increasing the load on.
You are loading on L2, which is already fractured.
Already leaked and fractured previously, so the risk of it developing a fracture within a few weeks.
Yeah, there is a tie between two Arvinds. There is a tie between two Arvinds. Yeah, Gautam, there is a tie between two Arvinds. Dr. Arvind Bhave feels that we should do a vertebroplasty above level. Dr. Arvind Goregaonkar feels we should not do it. So I think again it's a matter of your experience and the way you see your cases. No one is wrong in this.
No, you cannot keep doing a vertebroplasty above and above. Important is you treat osteoporosis after.
That is always there.
It is always there. Well taken, Dr. Goregaonkar. I would like to ask, we have MOA President Dr. Shinde sir and MOA Secretary Dr. Karne. They also work and do orthopedic and spine surgery as well. I would like Dr. Shinde, how you will treat this in Sangli?
We do vertebroplasty.
Okay. Yes, Dr. Karne.
Well, I treat osteoporosis first aggressively, and if the still patient has pain for 15-20 days after the treatment of the osteoporosis, especially teriparatid, then we think of the intervention.
Okay.
And my further intervention is decided by my spinal surgeon, Dr. Parasnis. I don't decide that.
Okay. You're
Dr. Karde, if you are waiting for that, it's going to take a long time.
No, but
already 3 months have passed.
Then you think about surgery.
If the patient has not taken, if the patient has not yet taken previous teriparatid is one which causes the bone formation. So if the patient hasn't taken in teriparatid, sometimes the patient's pain is because of the microfractures, multiple microfractures there, and if that pain goes immediately after starting teriparatid. So that is one of the clinical sign whether the patient is having the metabolic pain or whether the patient is having the structural pain.
So Dr. Karne, how long should we wait after starting teriparatide to see whether this pain will settle down or not? Maybe
generally the pain goes down immediately within 4 to 5 days. The severity of the pain, the whole pain doesn't go down
so fast.
It will be with calcitonin. It will be with calcitonin, not with teriparatide.
I don't think so.
It will be with calcitonin. In 1 week, they may say that pain is reducing, not with teriparatide.
Okay.
The action of the teriparatide takes
4
time
months.
to start. It doesn't happen. You take the tablet. It is not a crocin tablet that you take and within 4 hours the fever will come down. It is not going to be like that. It
Especially
changes
injectable
a lot of
calcitonium, which was
biochemical
available
changes
in the past.
body.
Okay.
Injectable
Bhave has a
calcitonium
point to
has
make
some.
that it takes time to get the pain relief. Yes, last word, Arvind Kulkarni.
So Dr. Karne has to wait for Dr. Parasnis to come. So that takes a month. So that's why he waits for a month.
Yeah, Arvind, what you will do?
So see this, I think, retrospectively, I think only vertebroplasty would have worked at L4.
Yeah.
See, these patients need to be counseled, these patients need a lot of counseling, there's involvement at multiple levels. The basic osteoporosis has to be treated. In the meantime, during the course of treatment, he might develop adjacent fractures. If the vertebroplasty alone doesn't work, then probably you might have to go and fix. Maybe you need a second surgery. It's not a straightforward.
No, I think it's a mixed experience of everyone, and I think I must compliment Priyesh what you've done. We have seen a case where similar vertebroplasty was done, and there was a collapse. The patient came to us 1 month afterwards, and he had a cauda equina because there was a complete burst, and the patient was blaming the previous surgeon why he did not do the fixation. A lot of things, if no one is right or wrong in this context. What he has done is a restoration of a sagittal balance, beautifully done vertebroplasty, and I hope everyone agrees that mechanically, if you see that, it looks a very strong construct. Yes, Priyesh.
One last question.
Yes,
One
sir.
last question.
Yes.
To PH.
Yeah.
Can I ask?
Yes, please.
As we are seeing, L5 inferior end plate was fractured. So was it
Mhm.
advisable to involve S1 at that time, or you still wanted
But
to
just
go ahead with-
yeah, I thought it's just a marrow edema. I purposefully
it looked kind of an end plate
emphasized the
fracture,
upper
inferior
layer.
end plate fracture.
So it
I
was an
thought that
inferior end plate
monoblock
fracture.
yeah,
Priyesh,
Yeah,
inferior end plate fracture. So that monoblock could have been
I went to
pressurized.
I went to good purchase at the upper end, like upper vertebral end plate. I went to the upper vertebral. The purchase was
See, biomechanics of loading is always the superior end plate is loaded rather than the inferior end plate. So if it would have been superior end plate, then I would have agreed with you. But if it is an inferior end plate, as in this case, there is not much loading which occurs post-operatively also. And that has already been proved in biomechanics that always superior end plate is more involved, and that collapses, causing kyphotic deformity, whether it is osteoporosis, tuberculosis, whatever it may be. So
Anyway,
the part has to be protected. What you are doing is a stabilization. You are just
many of these aspects of fixation and surgery, I think, will be brought about by the cases which Shailesh and me we are going to show you. And we are most welcome to intervene and ask. So before Shailesh loads his cases, just one more question I want to put to Dr. Doke and to Gautam and Arvind also.
I also want to.
We all do DEXA prior to fixations, especially in cases like this, right? So this case, it was minus 3.1. So Gautam also asked you that question, that is there any relevance of looking at the T-score or even Z-score in some cases when you plan how many levels you fix, whether you use cement augmented screws or different kind of constructs or hybrid fixations like this with MIS and something. So Doke, what is your opinion about constructs? Just one level above, below always, or 3 level or cement augmentation, and how you correlate it with the T-score?
So it's a lower lumbar fracture L4. And then I was able to create the lordosis as well. So I was happy with the 1 level above, 1 level below. If it would have been a bad collapse at a dorsolumbar junction, then definitely I would have to augment the fixation move, maybe 2 level above, 2 level below. So mostly I think more mobile. Mobile lumbar levels is very important, and I think the more we extend here, the more higher lumbar levels. Getting fusion at those levels is again going to be a problem with
Junctional, it would have gone problem at the junctional level as well.
Yeah.
And even in junctional level, you can add sublaminar wires also. If you feel that your screw is not getting good purchase, that is on table, you can decide and go additional posterior sublaminar wires. That will give you much more stability, because that is always a fight between the bony union and implant getting back out. So you have to win on this side.
So in this particular case, you didn't need to do laminectomy or any kind of destabilization posteriorly.
Yes.
Right? So it was
I did a sort of
So Ajay, suppose you had to go in, decompress and do all that also. Still you will stick to 1 level above, below, like you said, just because of number, or when do you go multiple level above, below, and how do you correlate with the T-score?
I think going multiple level at in lumbar or thoracolumbar, I think it's quite case based. So if we have to talk about, like if you do a laminectomy in this case, answering your question, then I think I would still go by, going a good posterolateral fusion in this particular case, because adding levels higher up, again, the biggest, I'm going to get a fusion at those higher levels where I've not done an interbody fusion. So I think even if I do a laminectomy in this particular case, I would do a very good posterolateral fusion and stick to single level as far as this case is concerned.
Absolutely.
Rajesh, what is helping and saving Priyesh in this case is the fact that he did a vertebroplasty at L4.
Yeah.
Whilst we are harping on posterior fixation, what you must not forget in osteoporotic bone is the importance of reconstruction of the anterior column. If your anterior column is not stable, whatever fixation you do posteriorly will fail. So what has helped, I think Vivek mentioned somewhere that he would have done only vertebroplasty. I would agree. I would still have done a vertebroplasty alone in this case first, and then if it didn't work, would have thought of fixation. But the vertebroplasty in the front, whenever you are thinking of posterior fixation, you must make sure that your anterior reconstruction is good. Otherwise, your posterior column, you are more susceptible to failure with anterior column failure in osteoporotic patients than in the younger thoracolumbar fractures. Now, you asked about the length of fixation. The length of fixation to an extent is not only determined by the type of fracture, but also the location of the fracture. If it's a lower thoracic thoracolumbar, I am more inclined to go longer because it is a junctional mobility, and I am forgiven because I am not losing too many motion segments. Now at L4, if you go long segment, you are losing practically all mobility in the lumbar spine. And in this mobile lumbar spine, if you lose mobility and this additional stiffness will cause junctional fractures. So what Priyesh has done is absolutely perfect. I probably would have added a vertebroplasty at the adjacent level to reduce the risk of a proximal junctional fracture. Other than that, the surgery is perfect.
Okay.
So what the patient was very comfortable the next day. Last 3 months she was in pain and the pain reduced dramatically. She was able to move, she was able to stand, she was able to walk. So good clinical outcome. The biopsy came out negative. We started the teriparatide injections to her and told her to continue it for a sort of a long time for follow-up. I had a 4-year follow-up of this patient and she is doing extremely well. This type of sort of a fenestrated screw we used to augment the cement. The only thing what I would have done in this case, I would have managed to get all this thing done percutaneously as well, because now we get this type of implant with the cement filler. So no need of open exposure, but I thought it's better to open and then maybe augmented more facet fusion and bone graft posteriorly.
It's
so yeah, as
good thing you did open, Priyesh. One of the problems of percutaneous screw fixation in these patients is that the rods are of not adequate lordosis. So what happens is in these patients, whatever is the existing curvature, you accept that curvature and you do an in situ fixation. The moment you try to correct the deformity, because you are correcting the spine to the rod, you are creating a void which then tends to fail. I have seen so many patients of percutaneous fixation in osteoporotic vertebral fractures where the implant has pulled out because the spine has been contoured to the rod rather than contouring the rod to the spine.
So excellent case, Dr. Doke. I think we'll go to the rapid fire cases now. And if time permits, time permits, Shailesh will invite 1 or 2 comments or questions per case.
Yeah, so by the time you are loading, all of us, can I ask everyone one thought-provoking thing? All of us are orthopedic surgeons. We are treating Colles fracture at day 1. We are treating at fracture neck femur at day 1. But we are allowing for 3 to 8 weeks for kyphosis to occur, patient to suffer from pain, should have bed, because these are all osteoporotic patients above age of 60 or 70. So are we justified when you are treating intracapsular neck femur on day 1?
Dr. Bhave, that is a different set of patients. Here, see, fracture neck femur patient, you cannot make them stand. Here,
this also you cannot make them stand.
Without brace, you can make them stand. It is
no. Those doesn't become indication for operating.
65 to 80% of these patients in 4 to 6 weeks become asymptomatic and they are habilitated. Let's not forget that. Also, let's not give a message here that the surgical outcome for these patients is very rosy. Remember, the complication rate of any of these surgical procedures, vertebroplasty, kyphoplasty, long-term, short-term fixations, it is not 10%. And these are old senile patients. Revision surgeries become difficult. A complication of a surgery is worse than the original fracture. I think most of the
I'm not talking for each and every fracture. I'm talking of the patients who require vertebroplasty. If we do little early, I'm not talking of day one.
I think the literature support is different. I think let's start with the
Shailesh, can you hear me?
So,
yeah, Shailesh is ready. I think this aspect, this thing we will take it at the end of the session. Shailesh, you start.
Just 2 points I want to make.
Yeah.
So now this Buchbender and the Kalmes report, publication which came in 2015, and the Cochrane database, which was again headed by these two authors from Australia and Canada. So these patients have been strong, proponents of not doing vertebroplasty at all. They're against anti-vertebroplasty, and I've been through their papers in detail and all the randomized trials of vertebroplasty versus no vertebroplasty. So only those situations where vertebroplasty was done before 6 weeks. So those are the only patients who have benefited from vertebroplasty. Otherwise, after 6 weeks, when you compare these patients who have undergone vertebroplasty or a sham procedure, the degree of pain relief has been the same at different intervals of time beyond 6 weeks. So my threshold for doing a vertebroplasty, let me confess, is 3 weeks. Okay, and there are many social issues also involved here. There are many social issues. Patients, their children are abroad. Patients who don't have domestic support at home, you want to make them up and about. You can't make them hanging around for 6 weeks, 8 weeks, etc. So my threshold is 3 weeks. And looking at these papers, the best relief, the instant pain relief, is between the within 6 weeks, because secondary structural changes happen post 6 weeks. Like there's local kyphosis, there is significant stress on the facet joint, the significant strain on the supporting ligaments, etc. So my threshold is 3 weeks.
Yeah, Arvind, the same study also mentions the complication rate, like cement extravasation and others, is much early in the very early period also. So I think what you're saying is that there is a window period, maybe 3 weeks to 6 weeks is optimally best to go in, right? And plus customization of every case. Shailesh, I think we can start, otherwise the time is good to go, right? Yeah.
Yes, Dr. Shinde wanted to say something.
I have one case I would like to present.
Yes. Sir, I will just finish this and then you can keep ready. We'll quickly go through.
Okay.
Or you can present and then I can run through my rapid fire. You can.
Yes, I am ready. I can present.
If you're ready, then I will just hold on. Yes. You can share your screen now.
Yes.
In the meanwhile, I'll ask Arvind that though these two reports are saying that the sham procedure is equal, there are multiple reports which say that vertebroplasty is really helpful. And our core clinical...
So these two studies, they claim to be level 1 evidence. So all these papers, they're all personal experiences. So you cannot compare a randomized control study with individual level 5 evidence papers.
Evidence based and.
So Arvind, now this vapor study has come latest, which is also prospective study. You please go through this.
Yeah, so that is the study I'm talking about. The vapor study is one study which has highlighted the importance of vertebroplasty. But again, those were patients who are admitted for pain.
Yeah, that is admitted. Those are not getting controlled at home.
These patients were underwent vertebroplasty within 6 weeks.
Yeah. So, and they are saying that first 3 weeks, if they have operated, those patients have done extremely well.
Yeah, I think this is a very interesting discussion because we have the 3 Arvinds and 1 Zaveri, A to Z spine. And we are having a great conversation. We are really happy. We would like to go with our president, Dr. Shinde sir, to see his case. Yes.
Shailesh, we need to have the take-home message
yes.
For a general orthopedic surgeon like us.
We have the take-home message, sir.
Yeah. 3 to 4 time where, and if the pain is worsening,
low back pain since 6 months, aggravated since last 2 months, was 8. Pain radiating to right lower limb, gradually progressive weakness in both lower limb, with urinary hesitancy since 1 month. History of trivial trauma due to domestic fall 2 months back. Known case of hypertension on oral treatment since last 2 years. On examination, local tenderness present at dorsolumbar and upper lumbar spine. This is her neurological status. Hip, knee, ankle, dorsiflexion grade 3, extensor hallucination, ankle plantar flexion grade 0, bilateral knee and ankle reflexes exaggerated, bilateral plantar absent, sensory disseminated, sensory diminution. These are the X-rays showing fracture T12 and L3. Next. These are the MRI showing T1 and T2 fresh fractures.
And fluid is seen in T12.
Any comments?
Fluid is seen in T12, which indicates that it is probably a non-linear type of situation. Yeah, yeah.
So comment I want to make is we need to see the entire full MRI top to bottom. From C1 to pelvis, all the way. The entire screening.
That we have done, but unfortunately for presentation, I have not included that films in this presentation.
Does it show anything about this?
Next.
The rest of the thing must be normal, no?
The rest of the things are normal.
That's why you have shown this.
That's why I have not included this. And these are the axial cut at D12 level. And these are the axial cut at L3 level. We did the investigation. Tumor markers normal, myeloma profile normal, USG abdomen pelvis normal, transpedical biopsy no pathology identified.
At which
normal? That is also normal.
But at which level?
So why did you do a biopsy?
That's why I'm saying.
Yeah, as it is at multiple level, that's why I did the biopsy.
But there's no soft tissue involvement anywhere.
Yeah, and you should.
And if you see the axial sections carefully, if your posterior elements are not involved, then this is a
Osteoporotic.
futile exercise.
अभी जो हो गया सो हो गया, अभी आगे बढ़ो यार.
Okay.
So I did the biopsy, and the biopsy report has also shown the treatment done. We decided to tackle the problem operatively. D10 to L5 posterior instrumentation with D12 laminectomy. D12 and L3 segments augmented with vertebroplasty, and L4, L5 TLIP was done for associated degenerative instability at L4, L5. And patient was started on injection teripeptide therapy post-operatively.
I think my question to Dr. Shinde is that L4-5 was a degenerative slip. Now patient had got a D12 fracture with retropulsion and neurodeficit. So I think this slip must be there for last so many years. And looking at the neurology, that was not the culprit. So was it really necessary to include that L4-5 and do a additional TLIP procedure? Because it made it very extensive.
Yeah, simple vertebroplasty really with a biopsy would have helped.
Neurological deficit.
Neurodeficit is there. At T12, there is a big retropulsion.
Yeah.
T12 you have to do. The main culprit. So L4-5, we could have easily, left it alone. That's my whole point.
Okay. Yes. One, we will take a quick answer from all the faculties. Yes, Arvind Kulkarni, what you will do? You will tackle the 4-5 or no? Yeah, Dr. Goregaonkar, sir.
Absolutely perfect. What Dr. Shinde has done. I would have included L4-5.
Okay. Yes, Dr. Zaveri.
Yeah, I think what Dr. Shinde has done is reasonable. I agree with what Ajay is saying, that 4-5 is not the symptomatic level. But the problem is that you definitely have to stabilize L1 and L3.
Okay.
You are going to go, your fixation is minimum going to L5. So therefore, by force, you are supposed to fix 4-5. At most, I may not have done a T-lift. I would have done a posterolateral fusion.
Lateral fusion. Okay. Yes, Arvind Kulkarni.
Yeah, I want to see the sagittal films.
No. Now we just on this.
Final.
Only thing is about this vertebroplasty, Shailesh.
Yeah.
You can see that tailing occurring in the pedicles.
Yes.
So you should not remove the needles very hastily until the cement sets.
Yeah, that's a very good point. Yeah. Absolutely.
And they are seen at both the levels of vertebroplasty.
Yeah. So we should give some time to settle the cement, and then we should take out.
Don't hastily remove, because along that track, the cement is going to come back, and that can cause root irritation.
Correct.
Fortunately, here it is in the pedicle, so no question of root irritation.
Point well noted.
Problem.
So
I'm asking one question. Why maybe the AHL grade 0 and ankle plantar flexion grade 0?
That can come from dorsolumbar spine.
Dorsal also.
That will be at
Those
compression at
Can
D12.
lead to these symptoms.
Yes, Arvind, quickly.
So
We have
probably
less time now.
from fixation point of view, probably I would have put much more longer screws.
Okay.
And probably nowadays what we do is in such long constructs to prevent rod failure, we put 3 or 4 rods.
Okay.
That's
Arvind is a minimally invasive surgeon, and he does a longer constructs, and that's a very a point well taken, Arvind. Yes, Shinde sir, what was the outcome? How was the patient doing at the end of it? Shinde sir.
During the procedure, we avoided tapping the pilot hole for having better screw purchase. Next, specialized HA-coated larger diameter screws were used for better purchase.
Okay.
Next, result L2 to L5 lordosis was improved from 5 degree pre-op to 20 degree post-op. Surgery has resulted in significant improvement in low back pain from VAS 8 to VAS 2. Day-to-day activity and sagittal profile of spine. Neurology improved gradually at the end of 3 months. Patient started walking with walker, and independent walking started at the end of 6 months.
Good.
Excellent.
Yeah,
Good.
I must compliment Shinde sir and about the great recovery and the surgery which you executed. And I visit this Gulf and African countries where they say when the president is saying everything is right. So I completely agree with what you have done, and actually a scientific job.
I just want one word from Gautam that now the whole lumbar spine has made stiff now. So your take on this? The thoracic mobility is not there, lumbar mobility is not there.
Sir, I would be surprised if within the next year or two she doesn't develop a dorsolumbar fracture.
Okay.
This is a very stiff segment over there, and there is a huge risk of developing a adjacent level fracture. Also, I am a little, I don't doubt Dr. Shinde's word, but in my practice, if I do something like this, patient is never happy. Okay, because in spite of this, they still continue to have a significant amount of pain and restricted movement, and they are never happy patients. So, but Dr. Shinde's patient is happy, and that's a very good outcome.
I ask you then what alternative I was having at that time?
Sir, send it to me in Bombay. I will take care of it. Patient will be unhappy.
Oh, that's a very good answer.
Patient will be unhappy with me, not with you, sir.
You fire really rapidly, Shailesh.
Yeah, my screen is seen there.
Yes.
Yeah, we will go now rapid fire. We have very less time. We will go with the different cases because we have seen a variety of cases, and we are really happy to see in the faculty interaction. We will be firing the cases now for everyone's experience. 49-year-old female related to orthopedic surgeon comes to us with back pain, lower limb radiation, and lower limb weakness. She is an operated case of CS cervix with metastasis treated with radiotherapy. And hips were weak, and this is what was her MRI. And the suspicion was the metastasis has gone to spine, and that is what they send it to us. And the next plan, what we should have done is we did a PET scan because we wanted to confirm and check as a routine, because we initially sent it to the oncologist and they referred it for a PET scan. We said, get it done, no problem. And the patient came back to us because of deficit. It was done the same day. Therefore, it was not much of a time constraint, and we had posted by getting her fitness. We planned for an anterior reconstruction decompression because the diagnosis was already there. Thinking that it may be a osteoporotic or maybe a tumor, but a deficit was important concern. And we had a detailed discussion with the radiologist and everyone. We planned for an anterior reconstruction as previously Dr. Zaveri was talking about. and we decompress the spine completely, and this is what we could achieve. And this lady is walking now. Her neurology is completely recovered, and there was no the pathological diagnosis was with the osteoporotic fracture. It did not show any malignancy.
So you are lucky.
Yeah, I was lucky. Yeah, I was lucky. And yeah, she went back to the previous surgeon. 65 female, alleged history of fall. Again, severe pain in the back, inability to sit and stand, immobilized. And I just want to talk about the important things in 2-3 lines. That level marking when we plan for a surgery in these cases is very, very important. We should never miss the level. A good exposure is important because we need a longer construct at all this level. Again, confirm the level, which level you are planning to do. And this is what we executed. A longer construct in osteoporosis is a normal say, because then we have a better chance, but still there is a chance of proximal junctional kyphosis or the distal junctional, DJK. This can happen because there is a level above level, but we have to get along with. This was a case of 78-year-old female, again comes with back pain, bedridden, not better, turning is painful, and multi-level fracture. There was weakness, and we went ahead with decompression in this case at both the levels. We stabilized with dual threaded screws. Nowadays we use these screws because they are having a better pull-out strength. They are better in comparison to the screws which we used to use. We use hydroxyapatite screws, coated screws, as well as cement augmented screws also. Again, a new case, 68-year-old female, fall at staircase and tumbled. She had a hip fracture as well as spine fracture. We had a T-score -3.2, discussed with the hip team. They felt that we should treat this hip as well as the spine. What should we do first? Because the patient was in agonizing pain at both the levels. We always think of doing the hip, but some surgeons prefer to do the hip in lateral position. Some prefer to do it in supine. They told that you fix the spine first and then we take over the hip, and that's what we planned for. We did both the level stabilization at one go, and we were lucky that this patient is now completing 6 months, and she went back to with a walker walking. We are just following with medication she's on. This is again a 65-year-old female, 4-level fixation was done in the past, comes to us with tumbling fall, and there is a fracture above level. If you see T-score -3, again agonizing pain, not better. She was very happy with the first surgery, and they wanted a permanent answer at the thoracolumbar junction. We preferred to do a stabilization in this case, and absolutely fine, nearing a year follow-up, and she's doing fine. We went completely up to the lower dorsal spine where we stabilized. We got a very good sagittal balance because we thought doing just vertebroplasty probably will not suffice. Again, as Arvind said, we always prefer a longer screw. We prefer a dual core screws, or we prefer hydroxyapatite coated screws in this kind of osteoporotic fractures. 79 female fall at home, decompression surgery 10 years back, and they were very happy with the surgical outcome. They again wanted a permanent answer because pain was excruciating. This is what the dual core screw we are talking about, and we will not go into the video. We will just talk about the dual core where we have a better purchase, and we got a better outcome. Again, is it that we don't get problems in osteoporotic? Yes, we do get problems in osteoporotic fracture. Again, a very demanding CEO of a company, completely better elsewhere operated, but comes to us with rod slippage. He wanted a permanent. He tried all the non-operative measures, not better. T-score -2.9. We planned for a reconstruction as there was osteoporosis. We planned for advancing the levels above and below by this approach, and we were lucky. We use this DBM, demineralized bone matrix, which is a costly thing, but still it's a very useful. That's what we have experienced in our practice. We could augment it above and below, and now we are nearing a very good follow-up with him. He's very happy. He couldn't lie down on his back. There was a poking sensation constantly on his back, and that is what we thought of connecting the above and below construct. Again, whether there is a role of sublaminar wire in spine, yes, this was an operated case of 70-year elsewhere, and she was with persistent pain. This was a short segment fixation done elsewhere, and the patient comes to us. I'm not saying elsewhere done is wrong, but this is what the patient comes to us with, and there was loosening of the implant, and we can see that was the reason for her pain. She was not been able to lie on her back. She was constantly lying on her sides, and we had no option. And she was a very frail lady. Therefore, we planned for a sublaminar wire, which really is a very good implant, as the lamina is a very stronger construct in even osteoporosis. And we have a very good experience of nearly so many years with this technique. We use it very specifically case-based, and this is what we did a very good contouring, and we managed to do this, and we got a very good outcome. This 5-year follow-up, this is nearly 7-8 years now, this patient got operated. And again, whether there is a rationale for cement augmented screws, yes, we have a 72-year-old female, severe low back, decreased activity due to pain, bilateral weakness, and this is double level fracture collapse. We planned for a decompression stabilization by using this dual core cement augmented screws, and we were really lucky to get a good answer. As we already spoke about the sublaminar wire, this is all the different modalities. An expandable screw is a new entity in the market, which is also picking up because of good pull-out strain. This is the last case which I'm talking about. A 49-year-old man comes from abroad to us with back pain, severe, not better. All medicines been tried. Kyphosis, severe sitting pain, walking pain, and operated for adrenal tumor with adrenalectomy. Known case of Cushing's, known case of type 2 diabetes, on insulin, hypertension, but in agonizing pain. Now his condition was, doctor, do something, or he was feeling like suiciding, and all these things. We thought of, we took all the opinions. This was a 5-6 level vertebroplasty, and it was a challenge because of significant kyphosis. We thought, how we should treat, whether we should, there were very less options, and then we thought of planning for giving a better deformity correction, because that was the reason for his sagittal misalignment and degeneration, which was causing pain. At the same time, the multi-level fracture. This was the case where there was significant kyphotic angle, and we took all the possible opinions, osteoporotic opinions, endocrinologists, physicians, everyone's opinion. And finally, the patient, we explained that there is a possibility, chances that this can happen, all these complications. And he was very much feeling, because he had suffered a lot. And we planned for, this is a paper which we have sent, how to put pedicle screw in a previously augmented vertebral body. And, we have to study the trajectory of the pedicle, and we can tap the pedicle, we can drill the pedicle in the previously augmented screw, and this is what we could get. And this is a very good outcome which we have got in this particular case. We planned for a D4 to S2, and as we we're lucky that this patient could sustain the surgery very well, and his pain is completely gone, and it's a long follow-up. He's walking and doing all the activities of daily living. So we were really lucky in this kind of challenging scenarios to do a D4 to S2, including the pelvis, including the thoracic kyphosis, getting a better sagittal balance. I was lucky that we had a very good team. Thank you for patient listening, and over to you all, guys.
Excellent cases, Shailesh. Anybody wants to ask any questions or any comments?
Congratulations, Shailesh. You showed a whole bunch of fantastic surgeries. It shows me that you know how to put pedicle screws. It doesn't convince me that your indications are correct and that your surgery selection is correct.
Okay.
However, we can always agree to disagree. The other thing I disagree is the constant word you use, that patient wanted a permanent solution. This is just an excuse for surgery. Put him on the table. What is a permanent solution? Can you guarantee any patient a permanent solution following an osteoporotic vertebral fracture in this kind of osteoporosis, that they will not develop an adjacent level fracture? Or with the type of degenerative cases you showed, whether they will not have pain, persistent pain? And when you dissect this many levels and patient you are cutting so much muscle, you are fusing so much of spine, do you think this patient will significantly get relief? So therefore,
we have a 3-year follow-up of this patient. He is doing extremely fine, and this is what he was not getting better. Everyone was trying something, and he was being treated extensively. This is not that this is what we like to instrument. We have very careful selection criteria, and in a gamut of so many patients, we do not offer surgery to all the patients. Only those who are indicated patients, who have significant pain, deformity, neurological deficit, those cases are being offered surgery in our institute. This is the routine for a long,
It is also very difficult to believe that all these patients are absolutely great and pain-free.
No, I'm not saying that they are doing great. It's not that. I showed a different gamut because it's not only osteoporotic fall and fracture. Therefore, we thought of getting some patients with tumor of, they are the routine cases which comes to your practice.
I think what we are highlighting is spine surgery is a branch where opinions may differ, indications may differ. Both, what Gautam and Dr. Shailesh, what they are saying is in your clinical practice, you have to have a clarity of what indications you will have, what surgical options you will propose, and the patients usually end up accepting within the available means, right? But most important, what both of them are also agreeing is compared to a surgery in a young patient, the senile osteoporotic spine patients who undergo long constructs may not have a longevity of symptom-free interval. If you really see the survival period of the surgeries, many of them do have, as Shailesh also mentioned, PJK or DJK or adjacent segment dual. So just like what we discussed last time of tuberculosis, osteoporosis is also a medical disease, is also something that you need to keep on tackling medically with exercises, with lifestyle changes, and do not feel that just because of the present problem is alleviated with long constructs forever. And all of us, all the faculty and panelists will agree with that. Am I right in summarizing this, Gautam and Shailesh?
Yeah.
Shailesh, do we have time to take my cases? Or
Yes, yes, definitely. Rajesh, go ahead, and then we just a rapid fire.
Just ask Sham.
Yeah.
Shailesh, you'll have to excuse me. I have some other commitments. I have to leave.
Yeah. Thank you so much, Gautam, for your valuable input.
Thank you.
Thank you,
everybody, for giving me.
Thank you, sir. Thank you.
Thank you, Gautam. Yeah.
Thank you.
Should I put my presentation in?
Yes.
Yeah, please.
Shailesh, in the meanwhile, I'd like to ask, with such a long fixation, how is the movements of the, just a stiff spine from D4 to H2?
Yes, sir. Yes, sir. It's a completely stiff spine, like what the patient.
Bamboo spine. It's a bamboo spine.
Yeah, but see, remember, these are old senile patients. So just forgive me for intervening, Shailesh.
Yeah.
Their mobility is anyway restricted. The flexibility which they require is anyway restricted. And we do this kind of long construct fixation even for younger patients when it demands. So if you are going in for surgery, do not compromise on levels. When the criteria is not there that let me stop at 1 level, 2 level, 3, whatever is required, because you need to safeguard the patient from an immediate revision or failure of the construct. Many a times, even continuing teriparatide or something like denosumab, you are actually protecting the constructs, because a porotic fracture can be an acceptable thing, but a failed surgery, extruded implant is a disaster. Now, let me just go through the gamut of cases to highlight a few points. I don't want to go, the same thing. This is the typical elderly lady, senile osteoporotic fractures persistent. Now, I'm showing you a standing X-ray. What is more important here is to see the kyphosis. We have failed to mention so far that one of the criteria to select surgical patients is how much kyphosis, whether it is a concertina plana kind of collapse or with kyphosis. If there is a kyphosis more than 30 degrees, your vertebroplasty or augmentation with cement is likely to fail. So in this patient, there was also, all the other signs of persistent pain and everything. So because of the kyphosis and the kind of presentation, we ended up doing this, and she has done very well so far, so good. But as we already discussed, she may come up with a problem. Now, another patient, 72-year-old lady, and where we did not want to do longer constructs, you can get away. But there was, fluid level, and you can see the amount of cement which has gone in. Right? So we corrected the kyphosis with positioning. We chose shorter construct instead of 3-3, where we have a good cement anteriorly. So every time you need not go 3 or 4 levels above below. Also, based on your intraoperative judgment of what is the kind of hold your screws have. Now remember, this problem of porosis you may come across where there is no porotic fracture. It is an elective surgery, like a TLIF or something. You go in and you come across this problem that a bone hold is not good. So do not abstain from having longer constructs. If not, you may come across this disaster. You see, there is some person has put the screws. Needless to say, is not a very experienced surgeon, because see the distal screws. One screw was through the nerves also. Now, when the patient presented, extreme problem, agony, skin sore near the implant hole distally, back out of the implants, retrolisthesis, progressive deficit, patient refused to undergo second surgery. Fortunately for us, we could put her on teriparatide. 3 to 4 months of teriparatide, we optimized the patient. So here you need to understand about risk stratification. This important word, especially about senile osteoporotic patients with a lot of comorbidities, you need to, overall see their chest condition, their overall metabolic condition, comorbidities, optimize the bone condition, then you go in. This was the plan, and then we operated. She did not recover a lot about her foot drop, but the pain came down to a reasonably tolerated level. She was off opioids and analgesics, and she has a reasonable lifestyle now. So here, what I would say that when you say the patient is doing well, we need to actually explain, right? What does it mean that patient is self-ambulatory, off the medicines, doesn't require support, and able to have a good quality of life without external help from others. Now, another fracture like this. Now, this was a fracture of L3, L4 both. Now, what should we do? Should we go in or no? This was the problem. More than the back pain patient are also saying claudication, like Arvind was always saying, look for stenosis. It is the axial scans which will tell you. Now here it is obvious, just putting cement is not going to help. Also, the MRI tells you sometimes which is the existent problematic vertebra. You may see multiple collapses. So select only the vertebra where you put cement in. Also, optimize the patient. So here what we thought that we were able to push cement to levels, but the other vertebral level, it did not take up the cement. That means there was consolidation happening. The trabecular strength was good. So we got away with shorter constraint. The patient did relatively very well. Now, another patient, 83-year-old man with back pain, with claudication, with severe progressive symptoms. You can see the collapse, pseudarthrosis, everything. Similar case like what Shailesh has shown. Now here, what we have an advantage is a simpler implant, very less cost. More importantly, through the transpedicular route which we had created decompression, you can put morselized grafts. Like Dr. Goraivkar just mentioned, sometimes putting the grafts inside is better. We don't have TCP, cement. Like what cementation does in peripheral bones, eventually it might create a lucency around, it might create osteolysis, it might still collapse. Putting bone and consolidation better, and obviously the teriparatide is very important. Another way of shortening the constructs, hybrid implantation, where you can use sublaminar wires with this. So remember that sublaminar wires are important in porosis because the posterior cortical bone is still much stronger. It is the anterior cancellous bone in the vertebral body which is porotic. So the screws do not have relative strength. That's why you have coated screws and cement augmentation of the screws or multiple level constructs. So always keep sublaminar wires in your. Now another case I want to highlight. We are managing osteoporotic spine. Our title today was not just osteoporotic fractures. So this was a lady, a classical stenosis with a lytic listhesis, with a lysis which was just a little mobile at L5S1. She had persistent claudication, a very busy practitioner, a gynecologist. She tried everything, nothing helped. She came up for surgery. Before surgery, the DEXA was done. I always tend to do DEXA for patients who have significant back pain also. This patient did not have much. DEXA was minus 1.6. So I take it as a cutoff from doing elective surgeries if the DEXA is showing T-score less than -3. Minus 2.5 to -3, I will do multiple level constructs. And this was minus 1.6. We went in, screw hold was standard. It was not great. It was not that bad. This patient persisted with back pain. She kept on coming back again and again. The gluteal pain was also there with subside, but the back pain was persistent. She went around multiple places. She even did a FT scan. Her CRP, HSCRP, ESR ruled out infection, but she took IV injections also. She was a very busy practitioner. So her workload was always more. So all these persisted for 6 to 9 months. 9 months down the line, this was the second or third CT scan, which showed clear pseudarthrosis and loosening around the implantation. So then we thought that this was loosening of the implants and going in. We repeated the DEXA, and then we had this kind of, reading that minus 2.6. So then after counseling, we put her on teriparatide and we revised the fixation above, below with more, BMP and bone grafting into the places. So remember, it is not just osteoporotic fractures which pose a problem in spine surgeries. It is elective fixation also, and sometimes you would be highly suspicious. So sometimes you have told the patient, I will do one level fixation. Intraoperatively find porosis, do not hesitate to go above, below, have sublaminar wires. Do not hesitate from doing a very proper anterior construct and still counsel the patient. Whenever the DEXA is doubtful, counsel the patient that revision surgery may be required. Spine surgery today is not a once-in-a-life procedure. Osteoporotic senile spine, they may require something further. Fortunately, she is doing excellent. Bone fusion is complete. She has not come back since last 6 years. Now, just to summarize and conclude, we have been talking about osteoporotic spines with vertebroplasties. Now, remember, this was a patient, multi-level fractures, operated vertebroplasties elsewhere 2 or 3 times. I might have done this also. I have come across these patient problems. You can see the lucency around that bone cement. You can see the haziness. You can see the loosening. Now this patient kept on having problem, and then she started worsening neurologically 6 months down the line from the index procedure, from the vertebroplasties. Now, instead of cement being present, the retropulse fragments kept on going backward. At the proximal level where there was a fracture, she started getting cord compression. She stopped walking. She could not even go around with a walker anymore. And then, instead of giving multiple blocks, facet blocks, root blocks, pain management, sometimes she used to come for admission indoors and IV management. Finally, the whole family with her, sons were abroad in US, they decided to go for surgery. And this is what was done. The first thing I will tell this patient is this may not be the end of the story. But if you can make a patient who's 75 years or plus, self-ambulatory, able to move around without the help of daily opioids or extreme NSAIDs, I think that is the purpose of such kind of construction surgeries in today's medicine in orthopedics. I will conclude over here. Topics are open. Otherwise, I'll ask Shailesh to conclude. Right, Arvind, Goregaonkar sir, Dr. Bhandari, Priyesh, any comments or any questions or pertinent points you want to come across? Arvind, before you start, let me ask you a question. I have done a few fixations where I feel that there is a very doubtful instability. It is a proper case 4 or 5 weeks down the line for vertebroplasty without much kyphosis. How many cases you have done with the MIS fixation above, below with a hybrid, cementation, cement augmentation? What is your experience?
So I've done quite a few. Hello?
Yeah. Arvind.
Yeah, I can hear. I've done quite a few of these patients with MIS. The only issue is the fusion is a problem. It's very difficult to put bone graft at the back.
Yeah.
So these are those patients who really have a stiff spine. Fusion is not a big deal. They are quite elderly because of arthritis itself. The spine is fused. Here, getting your wound healing is much takes precedence over fusion because these patients may not last long also. So
people who are very unstable or show a lot of mobility are not good candidates. Stiff spines where you feel additional augmentation will help, are the right candidates for MIS fixation in the cement.
Yeah, correct. And you see, the other thing is you should have, if the anatomy is very hazy, if you're not able to see your pedicles well on the X-rays, etc., they are not good cases because if you're doing a C-arm-based pedicle screw fixation, you're going to create problems for yourself and the patient on the table. So if you have navigation, the other thing is the amount of radiation. That is something which you need to calculate. For a 2-level fixation, you're putting just 4 screws. The radiation is probably acceptable. But if you're putting, 12 screws on top, 12 screws at the bottom, you can imagine the amount of radiation that you can get. So I have navigation in one of the hospitals where I work. So these patients, I usually take them there and do this. Then it is everything falls in place very easily. So with navigation, it should be a swift surgery without any with high accuracy.
I think very well said, Arvind, and nice cases. I would like to sum up by the concluding remarks that few of them are there as we have discussed in this spine webinar. The persistent pain and neurodeficit definitive indication is operative. Cement augmentation procedures are extremely useful in pain relief. You have to be very careful when you do the selection of the patient. Dual thread screws, augmented screws are very useful as their pull-out strength is much better in spinal fixations. Anterior reconstruction when necessary in osteoporotic fractures. Cement augmented screws definitely have shown better anchorage and in osteoporotic vertebra. Hard shell sublaminar wire is definitely not gone off the shelf. It is definitely one of the most important tool for osteoporotic fracture and collapse. Medical management is the key. Osteoporosis is a medical disease, and we all as orthopedic surgeons treating this disease, we should treat it very wisely, as most of the cases we can deal with medical management. I must congratulate all the faculty who have given significant time for us, studied their topics, and given us a very different perspective. The 3 A's, A to Z of the 3 A's, Dr. Arvind Goregaonkar, Arvind Kulkarni, and Arvind Bhave sir, and Dr. Gautam Zaveri, they have given excellent inputs. Dr. Ajay Kothari, Dr. Priyesh Doke, Dr. Vivek Deshmukh. They also were extremely good in their deliberation and cases. We really enjoyed, and Dr. Bhandari especially showing the vertebroplasty safe techniques. It was an amazing show. I was very much thankful for all the faculty, and especially Dr. Shinde, our president, Dr. Karane sir, showing significant interest and participating in our discussions. I compliment all of you to enlighten us by doing this webinar. And I conclude with thanking all of you and all the viewers who are watching this webinar today. Dr. Ashok Sham, who is the integral part of our MOA activity and helping us to deliver the good. We must compliment Dr. Ashok Sham for the great show which he has been putting up. Thank you, everyone. Thank you once again, and have a safe stay and safe life. Thank you.
Thank you.
Thank you. Thank you. Thank you. Yeah.
Thank you.
Thank you, Shailesh. Shailesh,
Yes, sir.
Thank you, Dr. Shinde.
I want to say something.
Yes.
That was an excellent session. As an orthopedic surgeon operating in periphery, some new tips like bicortical screw purchase, roll of DEXA scan and quantitative CT scan for preoperative planning, adjusting the cement quantity depending upon the fracture pattern is very helpful. I'm sure all the viewers have enjoyed the session as it was really informative and enlightening. I'm thankful to all the faculties and Sham. Thank you very much.
Thank you. Thank you.
And I would like just a few words from Karane sir, our secretary, Maharashtra Orthopedic Association.
Well, this masterclass is basically meant for the peripheral and general orthopedic surgeons. And as all of us know that general orthopedic surgeons try to run away from the spine, especially spinal surgery, which is seen apparently on the audience, which we see during the spinal sessions. But this particular, even when I attended, I thought that how much it will be useful to general orthopedic surgeon. Thanks to Shailesh, Parasnis, and all other delegates, that all other faculties, that you have made it so simple that now the people will have confidence they can treat it medically, as well as the most important thing is that even if they cannot perform the surgery, they did not have to send all the way to Gautam Jhaveri. They can do it in their own nursing homes with the help of the spinal surgeons. That confidence now they have got it. Thank you very much, all the faculties, for this.
Just a last note that everyone is right in their own clinical setups, in their own scenarios. No one is wrong. Someone has done this is not a wrong thing, because that is the experience of that particular surgeon. I must compliment my colleague Rajesh Parasnis for being there and a solid discussion with everyone. Thank you, everyone. Once again, thank you.
Thank you. Thank you, sir. Thank you.
Thank you, Shailesh. Thank you, Rajesh.
Thank you, sir.
Yes, Ashok, are we offline?
No, we are still online. Actually.
Okay.
He takes us.
Is Ashok there? Is Ashok there?
Yeah. Narayan, how are you?
Hi, quite fine. Good presentation. Actually, that presentation should be in a group of orthopedic surgeons, because these are the mainly spinal surgeons, and you require a little bit more time to explain what you want to say. But then the time constraint is there, and we need to see the other cases also. And done, there are other ideas, and especially the fixations. And so the time which was you required was a little bit more, but can be adjusted in some other conference.
Yeah. And I want to really encourage.
And we understand the idea behind you that every orthopedic surgeon should be able to do these vertebroplasty. The fear among their mind should go. That is your basic intention. That's why I said you should